Thank you all so much for joining us today for our Learning Disability Professional Senate Listen and Learn event, which we've called Working Together to Stay Well. We're very excited. We've actually had up to 350 people register. Not everybody's here now. I'm imagining people may be dipping in and out, but we hope that most of you will stay all day to hear some of the fantastic speakers that we've got. For people that don't know me, and I imagine a lot of you don't, my name is Viki Baker, and my day job is I'm the Clinical Director for Learning Disability and Neurodevelopmental Services in Sussex Partnership. I'm a speech and language therapist by background, and on the Senate, I represent the Royal College of Speech and Language Therapy. And I'm joined today by Professor Ashok Roy, who is a psychiatrist in the Midlands, and together we co-chair the Learning Disability Professional Senate. As if by magic, he's appeared on your screens. So I'll say a little bit about the Professional Senate and the conference later, but first just wanted to start with some basic housekeeping. Given we've got up to 350 people booked today, we've decided to turn off the chat function. It's just very difficult for us to manage with that volume of people. But if you've got any technical difficulties, then you can direct message Gemma Grant or Florence James. That's Gemma or Florence, who are managing the technical side of things. And in case we forget to say later, a massive thanks to Gemma and Florence, who have done all the hard work behind organising this conference for you today. So a massive thanks to them. The conference is being recorded, so you'll be able to access the recording afterwards. We'll be putting that on YouTube and the CBF's website, and you'll all get copies of the slides afterwards. So if you do want to contact any of the speakers today, they will have their contact details on the slides and would welcome any comments, questions or ideas you have following the event. We'll also be posting on X, formerly Twitter, and LinkedIn, and we'll have the details of that in the chat as well. We've got no intended plans to change what's on your agenda. Hopefully it will run like a slick and organised machine. And I will just say a little bit about the Senate for those of you that aren't aware of it. The Learning Disability Professional Senate is a UK-wide group, and we provide an independent clinical voice for people with a learning disability, their families and providers that support people. And most of the clinical professions that work with people with a learning disability are represented. Also people with a learning disability themselves, obviously through a range of networks, family carers through the Challenging Behaviour Foundation, who we're partnering with today, provider organisations, the CQC, Skills for Care, NHS England, and then we have reps from regional groups, and we have representation from government departments across all of our nations. And we debate and we discuss key issues and topics that affect the lives of people with a learning disability and their families and providers. We help set clinical standards, we develop advisory papers, we contribute to national policy, and we advocate on crucial topics that affect the lives of people with a learning disability from a clinical perspective. If you want to know more about the Senate, we've just put a link in the chat, and Ashok and I would welcome any questions you have about the Senate. So the conference today, if it's not obvious from the title, is about how we as systems work together to stay well, to enable people with a learning disability to stay well. We really hope you enjoy today and learn a lot from it. And I'm going to start by introducing our first presentation, which I'm very pleased to say is from Sussex. We are hearing today from members from the Involvement Matters team, Sonia Reid, Dr. Sarah Gordy and Jeanette Gallivan-Young, and also Emma Pearson's here to support as well. And their presentation very aptly starts us off, is called Let's Talk About Health. Over to you.
Thank you, Viki.
Welcome. Hello.
Welcome. I am a self-advocate and a member of the Involvement Matters team,
Co-chair of the East Sussex Learning Disability Partnership Board. I have won the National Leader Disability Leader Award for my work in the community. I am a member of the Staying Alive and Well group, which I hear you will hear more later. I also been a gold medalist in the Special Olympics. I will hand you over to my colleague Sarah.
Hi, I am a Dr. Sarah Gordy, MBE. I am a self-advocate and a member of the Involvement Matters team in East Sussex Learning Disability Partnership Board. I am a disability activist, ambassador for MENCA, and a patron of the Down Syndrome Association. I was the first woman with Down syndrome who been awarded a MBE for my work with the arts and people with disabilities. I was also the first person with Down syndrome to be awarded an honorary degree by the British University.
Thank you, Sarah. I'm Jeanette Gallivan-Young, Project Manager in the Learning Disability Commissioning Team at East Sussex County Council. That was quite a hard introduction to follow from Sarah and Sonia, but I have the privilege of working with the Involvement Matters team and other self-advocates in East Sussex. Next slide, please.
Who are the Involvement Matters team, I hear you ask? We are a group of self-advocates who have learning disabilities and are members of the East Sussex Learning Disability Partnership Board. The Involvement Matters team work together with East Sussex County Council and East Sussex Learning Disability Partnership Board to improve the lives of people with a learning disability across the county and further afield. We are self-advocates and peer advocates, and we speak up for other people with a learning disability. We know that people with a learning disability face many inequalities, and health is one of the biggest. We want people to have a say in how services are run and how improvements can be made to support people with a learning disability to live a good, healthy and happy life. Next slide, please.
The Involvement Matters team has been involved in the co-production of lots of health and well-being related work. We would like to share our experience of healthcare and the work we are involved with to promote health equalities for people with learning disabilities.
Thank you, Sarah. The Involvement Matters team were involved in identifying the need for and the recruitment of our East Sussex Learning Disability Health Facilitation team. We host Let's Talk About Health meetings to continue our work with the Learning Disability Health Facilitation team and other health colleagues. We provide feedback on our experiences of annual health checks. Sonia has spoken at 2 webinars about health inequalities on respiratory problems and constipation. We supported Maxine's team, who's on the agenda today, I believe, to develop an easy read respiratory checklist. We participated in a meeting and a report by the Nuffield Trust, who work to improve the quality of healthcare in the UK. IMT worked with our leader programme lead on raising awareness about checking your blood pressure and the Know Your Numbers campaign. And we supported the development of easy read information for the national charity Blood Pressure UK. Next slide, please. IMT supported with easy read information for our local diabetic eye screening programme. We took part in work on the East Sussex Pharmaceutical Needs Assessment. We developed an easy read version of the East Sussex Whole System Healthy Weight Plan. We supported the University of Manchester working on a research project looking at how to improve hearing services for people with learning disabilities. We completed Learning Disability Today's health survey. And we've participated in local and national focus groups hosted by Learning Disability England on the Stomp and Stamp programme. The Involvement Matters team have also been key to providing feedback on what's good and what's not so good about healthcare, which Sonia will tell us more about now. Next slide, please.
What's good and what's not so good? It's good when I meet someone who understands and interested in me. People want to do their job well by helping me to get better. People communicate with me and listen to me. People smile and put me at ease. Next slide, please. Information is clear. I am supported to understand what is wrong. I'm told that my medication is from and how it will help me. I am included in decisions. I am seen as me. Sarah is now going to tell you about some of the things that aren't so good. Next slide, please.
Thank you, Sonia. There are some of the things that our experience has told us are not so good. I know I will have to suffer, even if it's not necessary, because someone is not thinking clearly about me. I am talking about and not with. I have worked hard to give you information that you do not look at or take seriously. My information will help you to understand me, or my information will help you understand me, or even save time, but you still not look at it. Next slide, please. It feels like you really do not have time for any of this. It feels like I am a burden. I am seen as a medical condition and not as a person. Someone does not value my life as important. Next slide, please. And finally, it's not good when I am not taken seriously. My illness is not seen because people are looking at my learning disability instead. Over to Sonia.
Thank you, Sarah. Pass It On project trains people with a learning disability about mental health. It talks about how to keep yourself well, how to pass on what you learn to other people. I am one of the first Pass It On educators to be trained. Next slide, please. The Environment Matters team work with Foundation People with Learning Disabilities and London South Bank University. Together, we want people with a learning disability to understand mental health better. We want people with a learning disability to learn the skills to help themselves to stay happy and well. Next slide, please. Together, we are helping to spread the word so that people with a learning disability can understand mental health better, help them to feel well, and know where to go for support. You can find out more information about the Pass It On project on the Foundation of People with Learning Disabilities website. Link in the presentation slide. Over to you, Sarah, to tell you more about important research with the Down Syndrome Association. Next slide, please.
I am supporting some important research in the fight against Alzheimer's disease. The ABATE study is testing a vaccine for Alzheimer's disease in people with Down syndrome. We want to see if the vaccine is safe, how it works inside the body, if it shows down memory loss, and thinking problems. If you would like to find out more about the BATE study and how to get involved, there is further information on the Down Syndrome Association's website. There is a link in the presentation slides. Next, we will hear from Sonia about her work with the Staying Alive and Wellbeing. Next slide, please.
I am a member of Staying Alive and Well Group. We are a group of people with learning disabilities, but people who support them. It is a national group commissioned by the NHS England, working on health inequalities and the LEADER programme. The group helps to think about the LEADER project and meets every month. The group talk about all the reviews of people who have died. We also talk about why they died. The group thinks about what is going well and give our ideas about how things could be better. We help to verify areas that need further attention and get the views of other people with learning disabilities. We developed a settable version of the LEADER report. In 2022, the group published their first easy read version of the annual LEADER report, including a settable video. In November 2023, we released the easy read report and a video challenging "Can you spot the difference?" We are currently working on the latest report. Next slide, please. The group made a video introduction to the full 2022 annual LEADER report. We have been a very clear message. Please take action. You can find further information and a video on the King's College website. Link in the presentation. Next slide, please.
Thank you, Sonia. Really important work. And we've heard the hard-hitting facts from the LEADER report and the Staying Alive and Well group's work about people with a learning disability dying too young. Sarah and Sonia are going to share with us some key messages from the Involvement Matters team. Next slide, please.
We want people with learning disabilities to live a good, long life. Next slide, please. People with learning disabilities should not be dying from conditions that could be prevented. Next slide, please. We want people with learning disabilities to have equality access to a healthy diet and the chance to exercise. Next slide, please.
We want people with a learning disability to be supported to talk about their health and their symptoms. Next page, please. We want people with a learning disability to be heard if they are feeling unwell or uncomfortable. Next slide, please. We do not want to be ignored or our symptoms put down for having a learning disability. We don't think this is too much to ask. We are going to end our presentation with a quote from another member of the Involvement Matters team, Tim Scully. Over to you, Jeanette, to tell us more.
Thank you, Sonia. Tim has been quoted in an article by Chris Hatton, Professor of Social Care at Manchester Metropolitan University. This article talks about not viewing learning disability as a health condition. Chris's article finished with, "The last word goes to Tim Sully. a member of the Involvement Matters team at East Sussex Learning Disability Partnership Board. He contributed to the latest leader report Forward, written by the Staying Alive and Well group. Tim says, "It makes me angry knowing I'll have to suffer, even if it is not necessary, because someone is not thinking clearly about me." Next slide, please.
Thank you, Jeanette. A powerful statement from Tim. Please think clearly about us. Please take action. And most important, please continue to work together with people with a learning disability, using our experiences and in knowledge to shape the better future.
Help us to make things better for people like me, Sonia, and Tim. So far, us and others, people with a learning disability will get to live a good, healthy, and long life. Thank you for listening.
Thank you all so much. That was absolutely brilliant. Some very powerful words there, and thank you for all the work you do. And again, some key and stark reminders of what really matters to people. And that's why we wanted you to kick off this conference. This is about us working together to enable people with a learning disability to live long and healthy lives, as you said. And thank you very much for everything you're doing. And you've got your contact details there for anybody who wants to be in touch. And you talked about a whole range of projects that you were involved in, which I think people would probably want to know more about. But thank you all very much for everything you do. And I'm sure we have virtual clapping, but I'm sure there is clapping going on behind it. Thank you so much.
Thank you.
So we're going to move on to our next speaker now, who is the Chief Exec of the Challenging Behaviour Foundation. I'm sure you'll introduce yourself, Viv. And Viv's title of her presentation today is Working Together, Navigating a Broken System and Co-Producing Alternatives. Over to you, Viv.
Thanks, Viki. So my name's Vivian Cooper, and I'm a family carer, and I'll say a bit about that later. I'm also CEO of a small national charity called the Challenging Behaviour Foundation, and I'll explain about that shortly too. So Sarah, Sonia and Jeanette have shared their excellent work focused on health and how important it is for us all to work together. And I'm going to be sharing some general working principles, including working in partnership and co-production, but also the challenges that families face trying to navigate through a complex system to try to get the right support in the right place at the right time. So I'll start by explaining what we do at the Challenging Behaviour Foundation and why. Then I'll share some information we've gathered from families about their experiences and what support they need. And then I'll share some examples of work we're doing with a range of partners, which I hope some of you will also want to get involved in. Next slide, please. I have 3 children, and this photo was taken when they were younger. As a mum, my hopes and aspirations for all 3 of them are the same.
Can't hear, Viv. No.
You can't hear me. Is that any better? Can you hear me now?
That's fine, Viv.
The audio is good.
Yeah, okay. So as I said, I have 3 children, and this photo was taken when they were younger. As a mum, my hopes and aspirations for all 3 of them are the same, that they have happy, fulfilled and interesting lives and fulfill their potential. My son has a rare genetic syndrome, which means he has a severe learning disability. He doesn't communicate verbally, and he needs help with all daily living tasks. He also displays a range of behaviours that we find challenging, and some of those are life-threatening for him. The only difference between my son and my daughters is that he needs more support to help him lead a happy, interesting life. But that shouldn't be a problem, because we know a great deal about supporting children and adults with severe learning disabilities. And we know a great deal about challenging behaviour, how it is telling us we need to find the reason behind the behaviour and do something about that reason. The quote at the side is from the late, great Professor Jim Mansell, who reminds us that people whose behaviour challenges have the same needs as everyone else, in addition to special needs for help to overcome the problems their behaviour presents. They do not surrender their needs for personal relationships, for growth and development, or for anything else because their behaviour presents a challenge to services. They have the same human rights as everyone else. Too often, individuals with complex needs are contained, excluded, their needs are not understood, and we try to fit them into services rather than putting the support they need around them. We forget about how they may be feeling, and we disregard their human rights. Next slide, please. When my son was 9 years old, he had to leave home and go to a 52-week school 275 miles away from his family. There were no local services that could meet his needs. In 1997, I worked with others to set up the Challenging Behaviour Foundation because it was so difficult trying to get good information about how to support my son and understand his needs. It was also to raise awareness and ensure that the expertise that was 275 miles away could be replicated close to home so he could return to be near his family. Our focus at the Challenging Behaviour Foundation is on children and adults with severe learning disabilities who display challenging behaviour and their families. The CBF now has 3 interconnected areas of work, as shown in the triangle, to drive change at an individual and strategic level. Our information and support equips families and professionals with evidence-based information and practical resources. We have a small family support team, a helpline, and provide casework support. That family experience informs our strategic influencing work, trying to ensure policy and practice meets the needs of all individuals, including children and adults with the most complex needs. And the third interconnected part is sharing best practice, demonstrating evidence-based approaches that work and enable children and adults to have a good quality of life in their local communities. Next slide, please. One example of our work is through our co-produced and co-delivered workshop. When families identify a need, we work with them to design, develop, and deliver workshops that focus on practical strategies that help them to help their relative. These workshops model the approach we promote, working in partnership, families and practitioners working together as co-facilitators, sharing their combined information that will help people. Next slide, please. An issue that you will hear a lot about today is community support and services. We worked with families to co-produce this graphic to set out what that means. It means living with or close to family and friends, doing ordinary, everyday things, accessing specialist support when you need it, and being included, not excluded. All quite ordinary, but some people need a lot of support around them from lots of different people to make that a reality. Next slide, please. Families are important to all of us, and especially so for people who require extra support. The families of the majority of children and adults with learning disabilities provide lifelong love, care, and support and advocacy for their loved ones. The importance of families is recognised in legislation. Just one example here, reminding us that we are all dependent on others and relationships are key. But families' experiences are often that they are not valued or acknowledged for their role by the system as they should be. When families are asked what they want from the system, there are 3 broad categories that they tell us about. Accessing information. Information that is accessible, practical, timely, and explains what is possible, not just what's available. They want good support for their relative so that their relative has a good quality of life, and they want to be valued, included, and respected as partners. Next slide, please. Families are solution focused and can identify what is needed to achieve the outcomes they want, good lives for their relatives. This graphic was co-produced with families of children with severe learning disabilities who also displayed behaviours described as challenging. You can see that they have identified very practical support and service solutions to meeting the needs of their family. And today we'll hear about some work happening that is delivering what is needed, but it needs to happen everywhere for everyone. Next slide, please. When you have a child with a learning disability, certainly it was my experience, you expect the system to swing into action to provide the information and support you need as a family. The reality is that the system is multiple systems: education, health, social care, each divided into children and adults. And there's a legal system, a regulatory system, and they all have different rules, funding and eligibility criteria. And on top of that, there are regional variations about how the system is organised and operates. In children's services, this is acknowledged in the recently published Law Commission consultation about social care law, which identifies silo working and failing to focus on meeting people's needs. Next slide, please. We have worked with families who've shared their experiences, and they describe this spiral when they are seeking support. They ask for help. They don't receive the help they need. Either they're told they don't need it, or they can't have it, or it's not available. They're not satisfied with the response, which then generates a defensive response from professionals. And then the family is blamed, and so the relationship deteriorates. This type of relationship is not helpful for anyone. Next slide, please. We've worked with many families to explore the issue of trauma. It's quite common for families to be described as unreasonable or difficult. We carried out a survey of families asking about their experiences of navigating the system to get the support for their relative. The corresponding report, Broken, is on our website, and Dr. Peter Baker has published a journal article of the findings. Families described their interactions with the system, trying to get the system to understand and recognise the needs of their family member as causing trauma, resulting in the symptoms of complex post-traumatic stress disorder. The short documentary film has been produced and can be accessed by the QR code on screen. The system that is meant to be there to support families is instead traumatizing them. Next slide, please. From that work, families have co-produced an awareness-raising workshop. This explains how, why, and when the trauma occurs and identifies ways to avoid it. We need the system to support children and adults to stay well. So if that system is causing harm, we need to acknowledge that and do something about it. Next slide, please. This is a graphic co-developed with practitioners as part of the workshop, which explains to practitioners that if you start to experience the family as a problem, you should stop and consider why they may be behaving in the way you're finding difficult. Consider how they may have been let down before and how many times, why they may not trust you, and ask whether what you plan to do will further add to that trauma. There are very many well-meaning professionals who may be inadvertently adding to the trauma family carers experience, and if we can prevent that, so much better. Slide, please. An important issue in the system is around culture. Families and learning disability nurses co-produced a short awareness-raising film about the importance of culture. It is focused particularly on inpatient services, but has relevant messages for other practitioners and other services. It highlights the positive difference that a good culture can have for everyone, for staff, for people who are using the services, and for their families. Next slide, please. The film is available here, and you can, to watch it, you can scan the code or you can click on the link. Next slide, please. As I said earlier, families are solution focused, and I'm going to share some important work that promotes working together towards common outcomes. These are quotes from families, reminding us to be person-centered, to avoid being inappropriately cautious about risk, and highlighting the importance of developing and maintaining good relationships between practitioners, staff, and families. Next slide, please. Co-production is key. It's a widely used term, but sometimes it doesn't happen as it should. We co-produced a resource available from our website that has practical tips about how to work in this way and some case study examples. Next slide, please. One of our most important and ambitious pieces of work is our co-produced action plan. Transforming Care, followed by Building the Right Support, produced various reports, recommendations and plans that failed to deliver the systemic change we all want to see. Hopefully there is some reflection about why that was the case. Some families came together and set out the type of plan they wanted to see, a co-produced, lifelong, joined-up plan that links together and focuses on outcomes for the person. Multiple people from all different backgrounds with different experiences have contributed. It's a working document and includes lots of great work that we want to see as standard, not as pockets of good practice. We agreed to present it as puzzle pieces. They all need to be present and they need to be joined up to make it work. Next slide, please. To learn more about the plan, you can use the link here or scan the code. We want as many people as possible to contribute and to use it. It's hosted by the CBF, but it's owned by everyone, and it's designed so that it aligns with other work and initiatives, and it's a way of coordinating work within a strategic framework. Next slide, please. So to summarise, the key messages I hope you will take away today. Families have a wealth of knowledge and experience and should be valued as key partners. We all need to work together to deliver person-centred support. We need to be adopting a lifelong, holistic, person-centred approach to care and support. Don't underestimate the immense challenges and frustrations people experience trying to navigate a complex system to get the support they need. Trying to find a way through the system is traumatic. Support and services need to be coordinated so they work for the person, not in ways that are convenient for the system. Many issues, needs, and solutions are interdependent. Individuals and their families need the right support at the right time, in the right place, and that will deliver good outcomes for all. Next slide, please. And finally, the way to make that happen is to work together. Next slide, please. Thank you.
Thank you so much, Viv. As always, much food for thought. And I was just taken by the three basics things you said right at the beginning in terms of what a start reminder around families, just basic information that people understand that is accessible, quality support for relatives, being valued as partners, and then now really to think about the trauma that we can do as professionals working in the system. And I can't tell you how important it is to look at the CBF website. I always go, it's my first place to go often, both in terms of supporting families or professionals, because the sort of resources you've got on there are just fantastic. But the message is, and the message will throughout today will be to work together, which is the essence of it all, really. So thank you very much. And please do go and look at the CBF website if you haven't already. It's fantastic. So we're going to move on to our next speaker. We're running a little bit early, but I'm not sure anyone's going to mind about that. So can I introduce to you Dr. Kirsten Lamb, who is a very, very strong advocate for people with a learning disability and very well known by many of us for her brilliant work in terms of advocacy in primary care. But I will let her say more because she's going to be talking about sharing skills shaped by her work in Hertfordshire. Over to you, Kirsten.
Thanks very much. Good morning, everyone. I am a retired GP. I'm a fellow of the Royal College of GPs, and I chair the Royal College of GPs Special Interest Group in Learning Disability. This group has around 100 members, mostly GPs from all over the country. I just want to share the learning that I gained in Hertfordshire about the huge benefits of being able to work together across disciplines. We usually call this multidisciplinary team working, which is a great long title, often abbreviated to MDT, which, as everyone knows in the NHS, we do only too often. The aim of our multidisciplinary working is to help people to stay well and to manage and treat problems when people are ill. Hopefully, this presentation follows on positively from both Viv's presentation and the wonderful presentation from Sussex. So could I have my next slide, please? So who are the people that we need to bring together when we are working together? Well, there are all sorts of people who could be useful to help find solutions. I think Viv's infographic that she showed early on in her presentation really sums this up very well, much better than my one. Could I have my next slide, please? So working together in the multidisciplinary team. This is just an example of a team on the right here. The most important aspect of this process of working together is that it must be person-centered. The person with a learning disability must be at the center of the team, and anything we do must retain that process. The people who we might bring together will depend really significantly upon the nature of the problem. So could I have the next slide, please? So multidisciplinary team working, what does it actually mean? Who should be part of the team? How does the team work? Does this team stay the same for every situation? Does it work well? Are there lots of barriers to it working well? And what helps it work well? And is there evidence about whether these teams improve outcomes? So could I have my next slide, please? So who should be in the team? Well, as I said at the beginning, the most important person is the person with a learning disability themselves. They should definitely be the most significant member of the team. And then, as Viv says, family members are also really important. For a lot of people, and not everyone has family members who are there for them, but they might have partners or friends and relationships in the places that they live that are equally important. There are also all the people who support individuals in the community, such as paid carers, carer organisations, and the local authority. And then healthcare, as Viv's already says, is horrendously complicated. We have learning disability specific healthcare providers, so learning disability nurses, psychiatrists, and a whole range of allied health professionals, a list of many of them you can see here. We also have mainstream community health services for people. This, as my work was, could be a GP and all the range of staff, which are now hugely varied within general practices. That huge variation and huge diversity of people working in general practices can also be really complicated for people. But there are lots of other people who work in the community, such as pharmacists, orthoptists, audiometry, and importantly, dentists. And then there's the mainstream healthcare provision in acute trusts. this is often a really stressful and challenging place for people with a learning disability to be when they're acutely ill. Acute trusts, as we know, contain the full range of non-learning disability specific medical specialties, often with very little knowledge and understanding of what it really means to have a learning disability. Can I have my next slide, please? So NHS England have provided this multidisciplinary team toolkit, and it's divided into 6 headings. And if we just think about those headings in a little bit more detail, to really work out what might make a team work successfully. Well, communication is really important. Communication is really the be all and end all to everything that works well within the healthcare setting. And for this communication to work, the members of the team have to respect each other and avoid language that's specialty specific. So for example, if I was in a team working with someone in the community that might have a housing specialist, the person themselves, family members, a social worker, it really is not helpful if I start using medical jargon within that team meeting that nobody else understands. We must work across boundaries. Now, there are all sorts of modern techniques that can help this. Interestingly, one of the benefits of the COVID pandemic was that a lot of IT development happened. So in the health service, we often use a system called Microsoft Teams. That's a really useful way of being able to bring people together in real time. We must have shared goals and objectives when we're working in a team. And that includes being able to evaluate whether this bringing people together has been successful. We need to plan and design the team. Who should be in it? How is it going to work? And this must be based on the need of the person for whom we're bringing the team together, or it might be a service that we're looking at that we need to think about. When we're bringing a team together, we need to think about the skill mix of the people that should be brought together to make this work properly. And that's bringing together the right people for the right situation. And then, as Viv so eloquently described, the culture of the whole system is really important. This involves mutual respect. It involves the organisations for whom people work being adequately supportive of the concept of working together. You know, we might be working together across an acute trust, across a GP practice, across social services, a social care provider, and a family. They're a complicated range of different types of groups of people. Next slide, please. So when does working together and working with others in a multidisciplinary way really help? Well, there's a range of different circumstances. It can really help in the direct care of a person with a learning disability. We know that people with a learning disability from research evidence often have around 11 different other health problems, such as hearing loss, vision problems, maybe cardiac problems, lung problems, and so on. And so their medical care can be really complicated, and it can be really supported by bringing people together. We might need to work together to develop new services, to promote good health, to look at strategic planning and in the development of research. We heard the Sussex Partnership talking about their research activities. Next slide, please. So I want to use my experience in Hertfordshire and what we tried to achieve to just demonstrate some of those aspects. Interestingly, in Hertfordshire, the community learning disability services, particularly the nursing services, are part of the local authority. This is quite an unusual setup. The nurses are employed by Hertfordshire County Council. This really assisted in bringing people together with particularly around social care and social care providers to understand the real life of the individual with a learning disability. Next slide, please. So I'm going to just look at a few examples of what we did. So this is an example of a strategic change that involved collaborative working. This was a system established by our community learning disability nursing services, but with significant input from our experts by experience. It's really called the Purple Star strategy, but also involves the Purple Folder. The Purple Star is essentially a kite mark that services can gain that recognises their skills and abilities around making good quality, reasonable adjustments. The purple folder is really a sort of about me document, but also functions as a hospital passport. Next slide, please. So what is the Purple Star strategy? Well, it's a complicated process. It involves the service, that this might be a general practice or any other health service, doing a self-evaluation of how they're currently functioning. It involves developing a learning disability champion, an initial meeting with the strategy team, developing an action plan, building up an evidence log of what they're doing, having training by the self-advocate and a learning disability nurse, who will then assess them to work out whether they're worthy of being accredited. Once you achieve a star, you don't just keep it, you have to prove ongoing monitoring and annual review. Next slide, please. So these are just a few examples. This is our Hertfordshire abdominal aortic aneurysm screening team gaining their Purple Star. Next slide, please. And this is a GP practice in Bishop Stortford. As a result of their Purple Star, the practice was CQC highly rated. Next slide, please. This is the Hearts Community Trust receiving their award for their COVID vaccination programme, which included a walkthrough video of the service done by a self-advocate. And interestingly, also included a drive-through facility so that people could have their vaccination in the car if necessary. Next slide, please. I just wanted to talk about this service development multidisciplinary working that we tried to do. This process revealed some of the barriers that can arise when we try and achieve this. We brought together people with a learning disability psychiatrists who had an epilepsy interest, our local neurologists, our local learning disability epilepsy nurses, pharmacists, GPs, and had links with our local tertiary care centres such as Addenbrooke's at Cambridge. Unfortunately, this proved a really challenging process. For example, just one of the simple things, it was really difficult for the learning disability psychiatrist to be able to access referrals into the acute hospital for some of the investigations that might have been necessary for epilepsy. It was difficult to bring the learning disability teams together in the same place with neurologists. So it doesn't always go smoothly, but it's still worth trying. Next slide, please. This is the final example from Hertfordshire that I just wanted to share with you. And this was a joint project looking at dysphagia, which is otherwise known as difficulty with swallowing, and the risk that this swallowing difficulty causes in getting aspiration pneumonia. This was a clinical care multidisciplinary team project. First of all, it had a lot of guidance by an expert by experience. It was led by the clinical director of the community dental service, because having a healthy mouth, not having lots of bacteria around your teeth and gums, is really helpful to avoiding lung infections. It involved a highly specialist learning disability speech and language therapy to assess swallowing, a specialist learning disability physiotherapist to look at the posture that people use when they're sitting to eat. And it involved the learning disability nurse evaluating her caseload to look for people at risk of aspiration. And bringing all these people together has really helped people understand the risks of aspiration, to try and stay well and avoid hospital admission, and to reduce the number of hospital admissions. Next slide, please. I just really wanted to thank all the people that I worked with in Hertfordshire, because really I wouldn't be where I am now if I hadn't had that experience. The most important people I worked with were the people with learning disability in Hertfordshire, who taught me so much. We had a partnership board, but we also have a number of county council employed experts by experience, with whom I'm still in close contact. I worked a lot with family carers through Carers in Hearts, with care providers through the Hertfordshire Care Providers Association, with our county council commissioners, with the local nursing team, the local mental health trust, Hearts Partnership Foundation Trust, our local university, which is still one of the few that has a learning disability nurse training programme, and very importantly, all my GP colleagues and their practice staff, but so many others as well. And As a result of that learning, if I could now move to my next slide, I've had the great privilege to be able to work with others to establish this postgraduate certificate called Medical Practice in Adult Learning Disability. The aim of this training program is ultimately to develop the concept of learning disability physicians, specialist doctors in particular, who will be able to work in acute trusts to help people, and just checking my time, and to help improve outcomes for people. The curriculum and the presentation of the course is co-produced. We have students with both medical, so we have a lot of consultant physicians and others, but also learning disability psychiatrists, but also a range of allied health professionals taking the course. We have presenters from a wide range of backgrounds. The course has 2 modules, one clinical one, which I'm involved on with teaching, and a second module around service redesign. And we really hope this will develop a cohort of people with much more detailed specialist interest who will be able to help improve outcomes. So my final slide, please. Can I thank you all very much for listening, and I'll look forward to the next presentation. Thank you.
Thank you so much, Kirsten. And just again, and just to reiterate, it's not just the multidisciplinary team around the person, which is important, but as system partners in terms of some of these service improvement projects. And we're hoping that today we're going to highlight how if you just work around the person, it's not enough. But if we want to create, well, of course it's enough, but create system changes about working with all primary care, secondary care, specialist services, the local authority, the family and people themselves, in order to create bigger systems change. So thank you very much, Kirsten. As you brought us back to time, I'm going to move us on to our next speaker, who is Maxine Goodman, who works alongside me in Sussex Partnership. And we know that leader reviews have consistently identified poor respiratory health for people with a learning disability, increasing their health needs, reducing their quality of life, and contributing to a higher avoidable mortality rate. So Maxine is going to be talking about the work she's been leading in Sussex on prevention and management of community-acquired pneumonia for people with a learning disability in Sussex. Over to you, Max.
Thanks, Vicky. Morning, everyone. As Vicky said, I'm Maxine Goodman, and I'm the professional lead for physiotherapy within Sussex Partnership for the Learning Disability Services in Sussex. And I'm going to talk to you about some of the improvement work we've done recently in Sussex around respiratory care for people with learning disabilities. Next slide, please. So the improvement work that we've done is really set within the learning that we've gained from LEADER programme over the last 8 years, which has really highlighted a real need for us to address respiratory care for people with a learning disability. And I also wanted to acknowledge the Lewisham CLDT and the work that David Stanley and the team have done there, because they developed their integrated care pathway in 2016 with the Lame Fox. And that's had a huge influence on our pathway development in Sussex. They very generously shared their pathway resources and all their supporting evidence at the time, and we brought this back to Sussex, and we've been using it ever since to try and improve our community pathway for respiratory care. And then in 2022, NHS England were rolling out some funds to support projects around pneumonia prevention, and in the autumn of 2022, we were lucky enough to be given some of those funds. Next slide, please. So the overarching aim of the project, which was given to us by NHS England, was to try and support some pathway change in the prevention and management of community-acquired pneumonia. And given the time frame that we had to use the funds, which was around 5 months, we felt that the best approach was to situate most of the project activity in the early stages of an improvement cycle, which is really about engaging, listening, and finding out what was going on in the system in Sussex. Next slide, please. So these were the people who were involved in the project. We had a core group. We had lots of key contributors. We had an MDT reference group who we took the findings back to, and the governance of the project was overseen by Sussex Partnership Leads and the ICB. Next slide, please. So NHS England wanted us to use this suite of newly published guidance that had come out sort of late 2022 and into the early part of 2023. And they wanted us to use some of that guidance to frame the project work. Next slide, please. So we decided to focus in on this clinical statement that had been produced by the British Thoracic Society, and it was focused on the prevention and management of pneumonia for people with a learning disability. So in terms of it being a kind of new national guidance, it was a real gift to us coming from the British Thoracic Society, the BTS, because we felt like it was going to give us a bit of leverage with some of the mainstream services to help get the word out. And we felt that the message and the evidence in the statement was really important to get out to services to raise the awareness of risk and also the potential for a preventative approach. So the guidance in the statement brought together the most recent evidence and expert opinion and expert by experience opinion on the many risk factors that predispose someone with a learning disability to developing a community-acquired pneumonia. And the main message of the guidance was that these risks are modifiable. A lot of the risks are modifiable, and if they're detected early and managed, they can lead to much better health outcomes for the individual. Next slide, please. So, considering our Sussex health and social care system, it's quite big and complicated, as you can see. There are 7 acute hospital sites where people might be admitted with pneumonia, and they all have outpatient respiratory services. We've got 6 community learning disability teams across the county, and they're located within a mental health trust, which has had some challenges in terms of sort of developing physical health improvements over the years. And historically, I think we'd found it quite difficult to get support from the respiratory services, as they tended to be commissioned around having a diagnosis like asthma, COPD and bronchiectasis. And they didn't quite understand the need for a sort of preventative approach towards developing chest infections and pneumonia. Next slide, please. So our key objectives for the project were really to have a mechanism in place for ongoing improvement after the funds had run out, because we had to spend the funds by the end of the financial year last year, which was the end of March, and we knew that any work that we did was going to sort of throw up more improvements and more work that needed to be done, really. So we were quite focused on having somewhere that we could keep this work alive and keep moving it forwards. We wanted to scope out current practice in relation to the recommendations in the statement, and we wanted to use some of the time and resource to get the message out and increase knowledge and awareness of the risk factors and prevention. And we ultimately wanted to improve the pathways with the respiratory services in Sussex. And we also needed to ensure that we heard the voices of families and providers who care for people with a profound and multiple learning disability, as they are often some of the people who are kind of, mostly affected by respiratory health and using those services. Next slide, please. So the training and awareness activity during the project consisted of developing and delivering 3 webinars, each of which had around 80 to 90 people attend. We developed a guide for healthcare professionals and co-produced an easy read checklist with the Involvement Matters team, as Sonia mentioned earlier. And in the autumn last year, we had a comms launch in the ICB, and we attended the weekly ICB briefing webinar where we had 289 people from across the Sussex ICB, and we were able to talk about the work, the project and the resources, and those resources are now on the ICB public-facing web pages. Next slide, please. So this is the Easy Read checklist. We co-produced this with Involvement Matters, and it's designed really to be a tool to have conversations with people with learning disabilities, their carers, and to be able to take it to the GP to talk about their respiratory symptoms and risks. Next slide, please. And this is a guide for healthcare professionals. This came out of some of the feedback in terms of the general system, mainstream healthcare professionals wanting more information and wanting some guidance. So we adapted, with permission, one of the flowcharts within the document and produced it as an e-leaflet. And it's really designed to be an aid memoir for healthcare professionals in primary care to help with the identification and management of risk. Next slide, please. The listening activity in the project consisted of a carer and provider focus group, semi-structured interviews for 6 respiratory consultants across all the sites, the respiratory services in Sussex, and GP and healthcare professional surveys and interviews. Next slide, please. So the main themes that came through from the families and providers were, firstly, which chimes with the earlier presentations, the first theme was about navigating services and the fragmented nature of services in Sussex. Secondly, there was quite a lot of feedback around not being listened to, around where families recognise the very subtle soft signs that people they support have, where they know that there's that person starting to deteriorate, and they were reporting that they don't often feel listened to when they're talking to GPs and primary care about that, and they don't feel that they get the quickest response that they could. And providers were asking for more training on how to assess for deterioration. And the third main theme was about avoiding hospital admissions. So there was a real feel for where, particularly where, people with profound and multiple disabilities, being in hospital, say, just to receive IV antibiotics doesn't always feel like the best option. So there was lots of feedback and discussion about avoiding hospital admissions and what other sort of options there may be. Next slide, please. So this is now just kind of summarising the findings from all of the scoping and the focus groups, and with a little update on some of the work that we've done since and some of the work that we plan to do. So data was a big one. It became clear during the project that we don't really have data in Sussex which tells us about the prevalence of community-acquired pneumonia, how many people are with learning disabilities are getting pneumonia each year, what the antibiotic use is, and what the hospital admissions are like. So it was quite difficult to find that data. So we've joined up with other work streams in the Sussex ICB to ask our integrated dataset team to be able to develop the system so that we can try and pull some of that basic data. And we're also currently developing our Sussex Partnership database for the pathway and respiratory work that we do, so that we can understand now that work is taking place and see how it develops. And then in terms of the family and provider themes about hospital avoidance and responding to deterioration, we have got a really good initiative in Sussex with a team of people in the ICB who've developed a Stop Look Care initiative, and it's a booklet and a rolling programme of training which is designed to help families and providers assess and report and get a prompt response, get a better response to a deteriorating picture. So we're promoting and supporting that initiative with all the people on our respiratory pathway. We need to have all our therapists kind of using the same language, supporting it in their day-to-day work, and also promoting the regular training that people can access. And for the hospital admissions theme, we've got some improvement work starting in East Sussex, looking at working with the hospice service, the virtual wards and the urgent community response teams, together with the learning disability teams and some families, and looking at, we're hoping to be able to sort of develop a pathway to support hospital avoidance and early discharge for people who have got those higher respiratory needs. And then in terms of the annual health check, it was felt there was quite a lot of feedback about the need to improve the ability of the health check to be able to sort of join the dots and recognise the kind of multifactorial nature of the risks. So we're continuing to work on the ground with GP practices in our pathway. We're sharing our assessments. We're talking about risk. We're asking for support and help in managing those risks. But it would be nice to think going forwards about some sustainable training that we could do for the people carrying out those health checks to keep that alive, and maybe even evaluating the flowchart use. Next slide, please. And then this theme is really about detecting, this came through quite a lot, about our ability to detect frailty and the potential for developing chronic respiratory failure, and really being able to detect that early and have conversations about what options might be available for individuals. So some of our areas in Sussex still have limited access to the non-invasive ventilation services, NIV, and this is where people can get access to some of the higher level respiratory support, such as things like, you might have heard CPAP, to support either sleep apnea or if someone's has sort of chronic respiratory failure. So we need to do some improvement work around this going forwards, and the work's going to focus on really strengthening our clinical assessment and working with those NIV services to improve access and commissioning. And
2 minutes remaining, Maxine.
Thank you. We're also currently doing a piece of work to improve the capabilities of our staff in having conversations about advanced care planning, because that's important in this whole piece. So there's a couple of other pieces of work there, which I'll let you read off the slide for next phases of improvement. And I'm going to go on to the next 2 slides so I can finish on time. So this is just showing you a little bit of the data that we are starting to collect in SPFT. So since the start of the project last year, the start of 2023, we have been able to offer for 68 people a community level respiratory assessment and a multidisciplinary plan to support that, to support those needs. And 18 of those people we've referred to the respiratory services, and this graph just shows the types of interventions that they've been able to be supported with, from helping with their medications around managing their secretions and saliva, to helping with conversations around advanced care planning and escalations of care. So next slide, please. So successes, I think the real success coming out of the project is it does feel that we've got respiratory care on the map in lots of places across the system. We're now included in the terms of reference for the Sussex ICB respiratory network, so we can take a lot of these improvements forward with that. We've had excellent engagement from the secondary care respiratory services, and I think the consultants who we interviewed are now our LD champions in those services, which has led to much better joint working, greater access. And we've done lots of work within SPFT to improve our pathway working around with speech and language therapy and physio around saliva and reflux management and advanced care planning. And the last slide, just to show you a few outcomes that we've been able to collect. This is just really to end on, with the message that this is ultimately what we're trying to achieve for people. We're trying to have, support people to be able to use less antibiotics, to have fewer respiratory symptoms, to be able to get on with their lives, to have fewer hospital admissions, so that they can really just get on with what's important in their life and stay well. And this is a small number. It's 17 people that we were able to track a year before intervention and a year post-intervention on the pathway, and we can see a very encouraging shift and trend in outcomes for those people. And I think I need to finish there. So I'll go on to my last slide and just say thank you.
Thanks very much, Max. And I would really encourage people to have a look at those slides, because the outcomes are really fantastic. And as Maxine said, one of the things was just about getting this on the map for people. So we know in the specialist world of learning disability how important this is through the LEADER programme, but actually raising that awareness in the integrated care system with respiratory consultants was a really important piece of work. So we would really encourage you to think about that in your ICB. But thank you, Maxine. I'm now going to move us onto the break, which I'm sure people will be pleased to have a break. You don't need to leave the meeting, just stay as you are, and we will start again at 11:30. And thank you very much for the speakers for the earlier part this morning. Thank you. So welcome back, everybody, to the second half of the morning from our Working Together to Stay Well conference. I'd like to say welcome to Dr. Siobhan Brennan, who's going to be talking to us today about audiology, learning disability and autism project. Over to you, Siobhan.
Thank you very much, and thank you for the opportunity to talk about this project. This is something that has been really needed in audiology in terms of improving our care for people with learning disabilities and autistic people across the lifespan, really. So first of all, I would really like to thank all of the participants in this particular project who gave us their feedback, and it was really appreciated, because I know it can be upsetting talking about where care has gone wrong, and so we really appreciate all those efforts and the efforts of families and carers as well to support people to participate. I would also particularly like to thank Shanice Thomas and Marianne Day, who did a lot of the work around this project as well. So next slide, please. So one of the reasons that we really want to look at this in terms of general population, so hearing loss is prevalent in about 1 in 6 of us. In terms of the general population, that's considerably higher in the population of individuals with intellectual disabilities, and there are some populations within that group where the prevalence of hearing loss is very high. And this is applicable to all types of hearing loss as well. So next slide, please. However, we're not just interested in audiology in knowing about how loud sound has to be before we're hearing it. We're also interested to know about people's ability to differentiate between one sound and another. So we're interested in discrimination skills as well. If you can imagine, like going to the optician, where you're discriminating between one letter and another. In the audiology world, we're interested in that similar ability to discriminate between different sounds. And also, does that person have enough hearing to lead the life that they want to lead? And also, we're very interested in ear health as well. So potential for ear infections and ear wax, which we'll be talking a little bit more about later on. So next slide, please. Within audiology, like a lot of healthcare services, we have a major issue at the minute with workforce supply. So a current estimate is that about 1 in 10 of our posts is vacant. So we have a huge issue in terms of meeting waiting lists, and this is true across our services. And it's something that the profession is working really hard to draw people into the profession. Also, wax removal is the form that used to take has changed quite dramatically in the last 5 years. It used to be something that GP services offered en masse, and now that's decreasing the number of GP services who offer wax removal. And so there's quite a lot of work looking at how that can be, if it is moving away from GP services, how that the quality of that care can continue to be regulated. You may also have seen audiology popping up in some recent news stories where there have been some errors around diagnostics. And this has been particularly affecting children with learning disabilities, where errors have been made. And there's been quite a lot of work doing some deep dives into different services to see the extent of that issue and what we can do to address it. So these are some of the challenges that audiology services are focusing on at the moment. Next slide, please. So in terms of accessing audiology services, it varies a lot across the lifespan. And personally, I would really like to see easier access to our services. So we have a universal newborn hearing screening program, which is offered to every baby born, with a small number of notable exceptions who go straight to diagnostics. Then we have a targeted follow-up for some babies with higher risks of hearing loss, which is offered at around 8 months to a year old. Again, this is very widespread and standard practice. The school entry screen, however, is decreasing in terms of the number of parts of the country where a standard hearing check on school entry is offered, which is not ideal, because if you take a room full of 9-year-olds, for instance, with a hearing loss, only half will have been identified at birth because of hearing loss that happens later. So it would be, we're really hoping to hold on to that school entry screen. And of course, there's the NHS England Special Schools Hearing Programme, which has had a very, very successful pilot. And now that next stage is looking at how this can be implemented more widely. Then there's the annual health check, which I will talk a little bit about shortly. And the uptake of that obviously is increasing, and that has a hearing element to it. But as I say, there's more to be said on that. There has frequently been discussion of having a hearing screen offered to all adults over the age of, well, different ages have been suggested, but from 55 perhaps, but currently that is not available, but it keeps getting re-looked at. So next slide, please. So as was the Health Education England South Region Intellectual Disabilities Programme approached, well, they put out a bid, and the University of Manchester, the Manchester Centre for Audiology and Deafness, applied to do this project, which was funded by this programme, identifying workforce challenges faced by audiology workforce in the identification of potential hearing loss for people with learning disabilities and autistic people across the lifespan. So we were interested in both adult and paediatric services. Next slide, please. So the way that we addressed this, we had basically 3 strands of work. So we did some semi-structured interviews with people who had used audiology services. So people with learning disabilities who'd used audiology services, and autistic people without learning disabilities who'd also used audiology services, to identify themes in what they were reporting in terms of their experience. We also had small focus groups as well, where people could discuss that. And again, we picked out themes. We also interviewed professionals as well to see whether the themes that professionals were identifying in terms of the barriers they were facing in delivering good quality care for these populations was similar to what the individuals and their families were experiencing. And we sent a freedom of information request to audiology services across the country. I was warned before we sent this out, this is a fairly unpopular thing to do, and I was fully anticipating some fairly grumpy responses. However, I still maintain that it was well worth doing, because when we've asked the question in the past, the only responses we typically get back are from centres of excellence, centres who are already doing lots. And there's sort of like a dozen, and I can name these centres who I will get responses from. We needed a much broader perspective in terms of what all audiology services are doing across the country. So I still maintain that that was the right approach, and want to do it again as well. Audiology services may not be happy with that knowledge, but I do intend to do this again. So if we go on to the next slide, we got about, from that actually, we got about 90 responses. So we sent out to about 134 services. We got about 90 responses, which, as I say, is the biggest feedback from audiology services about services for people with learning disabilities that we've seen in the UK. So that was very exciting. So some of the themes, next slide, please. So some of the themes that were emerging were around service structure and training. So there were so many themes, incidentally, it's not going to be possible to cover them all in 10 minutes. So I'm just going to pick out some key themes that emerged. So I want to start just here with flexibility. So if we go on to the next slide. Flexibility was one area actually that we were doing okay with. The vast majority of services were reporting, yes, longer appointments are being offered, multiple appointments, variation in terms of what time of day suits individuals best. So we were quite pleased actually with the fact that flexibility was an issue that was being raised as something that was important to people and their families. And in fact, a lot of audiology services can and do offer some flexibility, but it wasn't all a pretty picture. So next slide, please. Transition was less encouraging. Now, we're aware that audiology is not unique in this, but we were finding that not nearly enough services, for instance, were offering easy read information on what people could expect from the adult service. That was less than half. I was really surprised to see we did not get 100% of sites talking about having a professional liaison between adult and pediatric service, but that particular figure, I suspect, was influenced by the fact that some audiology services, adult and pediatric individuals, will be seen within the same service. So perhaps they felt a liaison wasn't particularly required because somebody would stay within the same service throughout their lives. So there's lots to unpick there on transition. So that's a focus for us. Next slide, please. Managing expectations. Now, I think that this is really, really important. So there are some sort of inescapable aspects of hearing assessment in terms of we are using a range of different sounds, and people have very different emotional responses to sounds. So of course, we think of sound largely when we think about music as an enjoyable experience, but there are plenty of sounds that people find very, very upsetting, and we have to be very careful about what sounds we use. We also use quite strange sounds in audiology, which may not be appreciated. So there are some inescapable aspects of hearing assessment where we have to think about how we can address those. And then we did have one quote, having to keep repeating test procedure which had never worked with their child was a frustration for parents. So next slide, please. So looking at professional support, so a theme that had been identified by families was are they getting the impression that the professionals know what they're doing? Well, unfortunately, the sources of professional support was variable. Now, part of this will be the fact that some employers won't have these policies in place, but some of it will be that employers do have these policies in place, but the audiology staff on the ground are unaware of them. So I think that there's some very specific training around raising awareness among audiology staff about the support that's available to them. Also around training, it's fantastic to see the training that is now available to the workforce as a whole, the healthcare workforce as a whole, but this needs to be discipline specific in addition for audiology staff to know how to adjust their particular hearing assessments and so on. Next slide, please. So, for instance, the British Society of Audiology has multiple guidance documents on how hearing assessments and hearing aids can be fitted for people with learning disabilities, but actually there was a section of our site who had said they had never heard of them. So this is a concern and some work that the British Society of Audiology needs to do in terms of saying this support is available to you. Next slide, please. Access to audiology. Yes, next slide, please. Actually, I'm just going to go straight to what we were finding from here. Yes. So in terms of referral sources, we accept referrals from multiple different sources. In terms of if somebody wants to have a hearing assessed, we're very happy to receive it. And some audiology departments, but not all, will accept self-referrals. I think that that's really important. If a family directly approaches an audiology service, I personally think that that should absolutely be available, but not all services do that. But I just wanted to point out one particular facet of this slide, which was the very low referrals that we are getting from the annual health check. Only 20% of services were saying they were getting any referrals from the annual health check. And there's a question to be asked there. Is this because the hearing part of the annual health check does not identify those with a risk that needs hearing investigation? Or is it because if an annual health check is not complete, hearing is being omitted because it is not seen in the same priority as others?
Remaining, thank you.
Oh, sorry, righto. So I would just like to say I am doing a local project. So if anybody would like to get in touch and talk to me about the annual health check, that would be fantastic. I'm doing some interviews with people who are doing the annual health check about their experiences. So that would be great. And next slide, please. Okay. I'll just move quickly on because I've just got a minute left. So can we keep going, and I'll say when to stop. And you, of course, you'll have these slides. So I'll keep going in terms of there's a range of reasonable adjustments. And yes, earwax. So this is a much higher prevalence of earwax in individuals with learning disabilities. So it's an issue in terms of the wider population for about 2% of the wider population. In individuals with learning disabilities, we think that it can be problematic in about a third. So this is something that we really want to keep an eye on. And the fact that it is no longer available in a lot of GP surgeries, there's an RNID campaign looking at increasing access to wax removal services, but work is being done on that. And I would love to hear from anybody who has some thoughts on ways that we can develop that. And some audiology staff as well are training in that particular skill. So I'll just go on to the next, and again, one more slide. Oh yes, I would just like to highlight as well and finish on a positive note. We use soundproof rooms. Now, not everybody loves a soundproof room, but we did actually find a consistent theme from some of our participants saying that they could stay in a soundproof room all day. So I would just like to say that we have a space that, yes, we would like to work on making it as accessible as possible, but soundproof rooms we could maximize further because it is a site that a lot of people seem to like. And we would like to do some more work at the University of Manchester looking at people's experiences of soundproof rooms and how to make the most of those relatively unique spaces that we use. And next slide, please. So just many thanks again just to everybody who was involved in our project, and forgive me for omitting some parts because I was elaborating too long on others. So if you would like more information in any aspects of this this particular project, do get in touch. I could talk to you about it all day.
Oh, thank you so much, Siobhan. And we just can't underestimate how important hearing is for people and how important it is for people to get an assessment. And the amount of times I've heard as a speech and language therapist, oh, there's no problem with the hearing, and nobody's ever thought about it. So just reminding people and bringing bringing this to people's minds all the time is so important, especially as you said around some of the real basics around wax. It's not even just about people who've got other hearing difficulties, is it? So, and thank you for your enthusiasm and your energy.
Oh, thank you so much. And just sort of on one last point is just to say that if I refute any claim that we can't assess someone's hearing,
absolutely.
we can assess hearing. Absolutely.
Yeah. We should. An annual health check should be at least one point where people are thinking about it every year. So a reminder, everybody. But thank you, Siobhan.
Thank you.
We're going to move on to sight now, and Lisa Donaldson's with us, and she is going to be presenting on delivering an equal right to sight. Over to you, Lisa. You're on mute, Lisa. You're right. That's fine.
Sorry.
That's
thank you so much, Vicky. Sorry. And thank you so much, Siobhan. It's perfect segue, really, from the things you were just saying, Vicky, about hearing. And Siobhan was saying so passionately about hearing actually really apply to eyes as well. Often we're asking, how is his sight? And people are assuming it's okay, but no one's actually checked. So yeah, it segues really neatly, these sensory needs that often there's assumptions that are made. So just to introduce myself, I'm Lisa Donaldson. I'm head of the eye care team at Seeability, and we provide eye care in 25 London special schools. And we've just recently had, again, an announcement from the NHS that there will be a rollout of this service in all special schools. So we're celebrating that, but also waiting for the actual commissioning to take place. Next slide, thank you. At Seeability, we also are a social care provider for people with learning disabilities. We support around 250 people. The eye care work that we do, we've been doing for a number of years to really raise awareness of the incredibly high risk of visual problems in this population. Next slide, thank you. So if you have a learning disability, you're 10 times more likely to have a serious problem with your eyes. And 1 in 10 people do have serious sight impairment. You're also much more likely to have preventable visual problems such as high refractive error, that means needing strong glasses, cataract, keratoconus, which is a condition where the cornea changes shape and leads to blindness if intervention isn't received early on in the disease process, diabetic eye disease and detachment of the retina. And as with so many conditions that we've talked about, if you don't get a diagnosis, prognosis deteriorates, and often it can lead to permanent sight loss. The work that we've been doing in the schools was really to evidence and get better data on this prevalence. And so in our special schools work, we've published the largest study on this population, just under 1,000 children, and shown that they are 28 times more likely than their neurotypical peers to have a serious sight problem, with 30 to 40% of children needing glasses, which they're often not getting. At least half of the children needing glasses didn't have them in our study. And that's 10 times. So in the general population, it's 3 or 4% need glasses. And yeah, in our study, we showed that 44% of the children had never had an eye test. And for the autistic children, that went up to 75%. So really shocking numbers. That was with average age of 11. Next slide. Thank you. So I was just going to tell you a few sort of stories to bring it home. This is Sally, who was rubbing her eyes a lot. Everyone assumed she had an allergy or hay fever, so she was on all sorts of different drops for eye irritation. She was actually in pain from glaucoma, which was so advanced it left her severely sight impaired and wasn't treatable. And her mum's worked tirelessly to kind of get that message out there and get people screened for glaucoma, which is preventable if you get a referral at the right stage. Next slide. And Laura is another story, somebody who actually was in an elderly person's home because she was diagnosed with dementia. And it wasn't until in the home they saw her white pupils that they realised she couldn't see. She was referred for cataract surgery. She's actually supported now by See-Ability in supported living because there was so much diagnostic overshadowing, and her sight loss was being attributed to dementia, and no one thought to check her eyes. And then finally, this is the next story. Next slide is Nathaniel, who I met in his school at the start of our project when he was 14. He was severely myopic. Mum said he had no useful means of communication. He was profoundly deaf. That had been diagnosed. He'd had glasses as a very young child, but no one had realised the significance of it, and then hospital clinics had become too challenging. So as a 14-year-old, he was functionally blind in a class where he couldn't communicate. Happily now he's got glasses and he signs the bottom line of a letter chart in a standard sight test in an optician's, and he's actually at college and he's learnt BSL, but his life journey was going on a very different path for want of correction for his severe myopia. Next slide, thank you. So I wanted to just dispel some myths, and very much like Siobhan, we can test everyone. Now, as a profession, sadly, pathways aren't always there. Individual clinicians don't always, sadly, live up to that. So if you walk into your local opticians, it may be a challenge to access eye care. That's why See-Ability have an information and advice line, and we provide support for people to access care, because sadly, lots of people are accessing routine eye care in hospital clinics because of a lack of targeted community pathways, something I'll mention to you in a moment. But I just wanted to highlight the fact that 50% of all sight loss is entirely avoidable, and the leading cause of avoidable sight loss worldwide is actually needing glasses. So it's in our UK special schools, it's probably the same case. So everyone, when I ask that question, typically comes up with, glaucoma or cataracts, but it's actually just needing glasses, and people just aren't accessing them. And the other big myth I need to bust is that when you go to the opticians, very often when someone who's neurotypical goes, you sit down and you're asked to read the letters and choose, is it clearer with number 1 or number 2? And you sort of assume you're kind of sight testing yourself, which is what the fine-tuning bit at the very end is, to make sure everyone's happy with how it looks. But actually, the prescribing of glasses is an entirely objective assessment. We use a tool called retinoscopy to measure the length of the eye. So it's all about how big your eye is. Short-sighted eyes are bigger, long-sighted eyes are smaller. and astigmatism is an irregular shaped eye. So we can take that measurement just by wiggling a torch at arm's length. So Nathaniel, who I was telling you about, I couldn't check his retina, I couldn't check his eye health, I couldn't make an assessment of the level of detail he could see. And so, you know, a vision test, which he obviously can do now as well. And that's the problem with vision screening, because that is often focused on the ability to see detail and asking for a subjective request. We can also do that with pictures, we can do that with gratings, but there are occasions like Nathaniel when that can be quite difficult. And actually the most important tool is this retinoscopy to measure and see if we can get someone's vision corrected by with glasses. And also it should be said that having your eyes tested also does pick up, as we've talked about, glaucoma, retinal detachments, cataracts, and serious potentially blinding conditions, as well as being the only place in your body where you can see the microvasculature, so you can see signs of diabetes, hypertension, and the optic nerve often shows signs of, you know, that's part of your brain we're looking at as well when we look into your eye, so often picking up things, signs of neurological conditions too. I mentioned diagnostic overshadowing before, but I'll say it again because it's so important. If you look at a list of the signs of sight loss and the list of the signs of a learning disability or autism, there's so many parallels, and so many carers say, oh, he's doing that because of his autism, he's not making eye contact, he's not engaging, he's got no concentration, when actually it could be that someone couldn't see. So one of the top messages is just think, could that be what's going on, that there's an issue with someone's vision? If we are in a situation where sadly sight loss is permanent, if someone does have a brain-based visual impairment, if we can't correct their vision, if they have glaucoma that's advanced, or if they've had a retinal detachment, it's still really important to understand what vision someone has. Most people still have some vision, and the professionals who support that are vision rehabilitation specialists and low vision service professionals. And so getting access to them if someone is certified as sight impaired is really important. Another sort of really sad scenario we often see is where, because someone is registered as severely sight impaired, the vision they do have is just written off, and they're not supported to use it. And as a segue to that, even if someone is severely sight impaired, in 90% of cases, if they have significant refractive error, they will still benefit from having glasses. They'll still benefit from having a focused image to use, if albeit a damaged image. So it's really, really important that we still provide glasses. So you don't think, oh, well, he's sight impaired, forget about those thick glasses that are in the drawer. They're obviously not needed. That is absolutely not the case. Next slide, please. So as I said, we have an information and advice resource library. So if you ever see anyone who does have a diagnosed eye condition, we have resources about those conditions. We also have resources about getting a cataract operation done, about putting eye drops in for glaucoma, about going to have an eye test, and easy read, familiarisation visit resources about going for an eye test, so that you can go prepared, and in your valuable clinical time isn't all spent cross-examining someone about when they last went and what glasses have they got and what do they use them for. So actually we get someone to fill out that form, sometimes with a supporter if needed, so that they come armed with all the answers, well, most of the answers to the questions that the clinician might have. And we also at Seeability have 4 eye care champions who are employed by us to get this message out there to their peers. So they go around advocacy groups. They also increasingly speak peer to professional as well, because that, you know, obviously it's to hear that nothing about me without me, and to hear that from people with lived experience. Grace, one of our eye care champions, has experience of being diagnosed with a psychosis and put on antipsychotics when actually she was losing her sight to glaucoma. And so she was experiencing Charles Bonnet syndrome, which is where you get visual hallucinations because you've got sight loss. And Grace talks very eloquently and emotively about that to all sorts of audiences. And so they work to do that. We're also working to try and get, as I said, a special schools pathway where hopefully, you know, there's been a renewed promise just this last week to roll this out in every special school, along with the audiology services in residential schools, which is a disappointment because we think that they should be in all special schools too. But we've had that commitment. That's still not at the moment. There's only services in about 9% of
to
schools.
go. Thank you.
Thank you. And it's really important that those services, when they are commissioned, are quality services that are, as we said, making sure that all the children who do have visual impairment are getting referred on to teachers for the visually impaired, that the support's in place. One of the things we do in our special school services is write a written report for all the children, so that the whole team around the child, including speech and language, even physios who might not understand that a child needs to turn their face to one side because they've sight loss on one side, for example. So understanding what people's clinical diagnosis practically mean to their the visual support that they need. Next slide, please. So yeah, I've talked about the special schools. I've talked about, we also really want to get specialist primary eye care pathways commissioned, and the champions have been heavily involved in that. We have a pathway called the Easy Eye Care pathway, which is commissioned in 4 ICBs at the moment, and we'd really like to see that commissioned further. It's where local community opticians have additional funding, and they do additional training to be a specialist centre of excellence in their community. And really just everybody here thinking vision, that we just said about audiology, you know, thinking about those sensory needs and making sure that annual health checks particularly echo what Siobhan has said. You know, we don't seem to get many referrals from those into the Easy Eye Care pathway. So really important that vision's just embedded in every aspect of things. Next slide. And that's just me saying thank you. And yeah, wonderful opportunity, really appreciate it. And do have a look on our website, do use our resources to encourage people to go and have an eye test. And thank you so much for this opportunity and for listening.
Thank you so much, Lisa. Again, I keep saying the same thing, but so much there, and just the real basic message, we can assess everybody. There's a really, really higher incidence in people with a learning disability. There's lots of misdiagnosis and diagnostic overshadowing going on. Those 3 case examples were just extraordinarily powerful, and that we all have a duty to make every contact count and always be thinking all of these things for everybody. So think sight, think hearing, and I'm sure we'll be thinking other things, but thank you so much. I'm going to move us on now to our next presentation. If Kathy's here, can I introduce Dr. Kathy Peterson, who is going to talk about her work called Prevention of Adult Not Brought Strategy. Over to you, Kathy, because you can explain it in your presentation.
Thank you, Vicky. This is a whistle-stop tour. It's lovely to meet you all, and thank you for inviting me, Vicky. My name is Kathy Peterson. I'm a GP partner in Cramlington in Northumberland, and also strategic clinical lead in learning disability, mental health, neurodivergence, and wider determinants in North East North Cumbria ICB. Next slide, please. One of my jobs in the practice, and has been for many years, is learning disability annual health checks and also the severe mental illness health checks. And I did notice when I was doing these checks that people didn't turn up sometimes, and I really wasn't sure whether they had made a choice not to turn up or whether they couldn't have brought themselves. And we're very sighted on children in this work. So when a child doesn't attend a point where we call it child not brought, because obviously they couldn't have brought themselves, but we're not really cited on this for adults. However, NHS England have made recommendations about this, but not a framework around how we work with it. And I also noticed that I couldn't document it. All I could document was didn't attend, which of course isn't really accurate or right in this setting. So I asked for a way of clinically noting that. We call that coding in medicine, so that we could recognise it and do something about it in the medical notes. And then I went on to spend about 4 and maybe now probably 5 or 6 years thinking about how we do this better. How can we put a framework around this so that patients feel supported, carers feel supported, and we all do this better? Because really this is a system failure. We're not doing this right. We're not thinking about our vulnerable patients first. So we talked to health and care professionals, patients, carers, and I worked really closely with our North East North Cumbria Learning Disability Network to develop a strategy. Next slide, please. So as I say, we could only ever write DNA before, and this isn't either appropriate or accurate. And obviously, we need to write it and then do something about it. And for me, this is about making proactive, reasonable adjustments. The other thing we do with it is if a child hasn't attended, is we ask questions. We say, oh, actually what happened? Is there anything we can do to support you? Could we, do a re-referral? Because obviously you missed her appointment. We don't do that for adults, and I think we should. And I've used the word prevention of adult not brought strategy, the prevention word is because this is not about blame. No, this is nobody's fault. In fact, if anything, it's the NHS and health and care system failure. Thank you. Next slide, please. So we have commissioned Teesside University to do an evaluation of this work, and they've put together a lovely infographic, I hope you'll agree, showing how it can go badly wrong and also how we can do it better. And I think most of us who work in clinical work or work with patients or people know how to be kind and do this properly. Next slide, please. The problem is that we just don't actually do it, and we don't do it in a systematic way. So as I say, I've started with learning disabled patients, but actually this applies also to autistic people, perhaps people with ADHD, people with severe mental illness or multiple complex presentations such as homelessness, particularly for people living with frailty and dementia, people experiencing domestic abuse, people without English as a first language, and people with sight and hearing loss. Now, we use the sort of generic term of vulnerable adults, but actually this encompasses also our people at risk of lack of capacity or fluctuating capacity, so that's perhaps our delirium patients. And it also includes our people who are over 16, but under 18, who by law have the right to make their own decisions if they have capacity. I also think it pertains to the people experiencing the need for care under the Care Act. And I've put a question mark because I think I probably haven't got all of the groups that might benefit from this approach. I was challenged earlier this week on condition-specific things like people who need dialysis to be well and stay alive. So I think for me, this is a framework for you to look at it. This is not me dictating to you exactly how you do this. Next slide, please. One of the problems with this work, and in fact the evaluation has been that we really don't know how many people this applies to because we haven't been using the code until I think about 2021. And because of that, we don't know the size of the problem in terms of missed appointments or tests, and we don't know how many people have been discharged from clinics. Mine and other clinicians that I work with experience is that this is quite significant in our vulnerable adult population, and it actually happens several times. So it might happen repeatedly for a patient, so perhaps someone in a care home. And one of the problems, of course, is that capacity to make decisions and capability are decision specific, and they are very, very difficult to do and often need a multi-agency approach. Next slide, please. What I hope to get to a point of doing is that we are recognizing these people who might be at risk. We are marking the notes, for example, using hospital passports or the reasonable adjustment digital flag. And we are then making it reasonable adjustments from the first point of contact. So that might be appointment setting in primary care, in our general practice surgeries. It might be making adjustments in the opticians. It might be making adjustments in hospitals like emergency departments. And for me, those reasonable adjustments are well documented, but actually it really means that we have to think about the flexibility of timing, of setting. You know, how do we make sure the carer, the trusted carer is there? And that's really about, you know, if they can only come on a Friday, then the appointment needs to be on a Friday. And the final part of that is to assertively follow up patients. Next slide, please. In North East North Cumbria, we've made some lovely posters advertising reasonable adjustments to our professional colleagues, to our patients, to our carers, and to a really wide group of people, including our young people. So please do, when you get the slides, have a look at all the resources we have, and please pinch with pride. Next slide. So I have some quite lofty aims with this work. I mean, we'll have to see how it works. But if people attend their appointments because they're able to be brought, because we can be more flexible, we can increase vaccination rates, we can increase rates of annual health checks and long-term condition checks. We can also think about completed investigations and diagnostic processes, making early diagnosis quicker and more effective. And I hope that we would reduce the loss to follow-up, the discharges from outpatients due to non-attendance. We also hope to reduce emergency admissions because people have been diagnosed earlier. And a big one for me is that stress and trauma of attendance for patients and carers. It's really stressful. One of my carers told me that she had 50 appointments last year. Now, with the best will in the world, most of us cannot achieve that, either because of health conditions ourselves or work or whatever. We need to be more rationalised about how we offer appointments, and they need to have high value. Next slide, please. So there's lots of things we can do, disseminate those posters, think about the materials within this strategy, and also think about workforce education. The National Digital Reasonable Adjustment Flag work is really crucial here. We are a fast follower in North Cumbria. That means that we are quite far on with this, but we're still not anywhere where we need to be. I can do it in my notes, but it doesn't get seen by my secondary care colleagues currently. I also think we need to be referring and highlighting any particular vulnerabilities so that our colleagues in secondary care can be they can be aware. And we need to think about how we can best support it using the whole team and working together. The other really big driver for us is the mandatory training and learning disability and autism Oliver McGowan training. And that will help us also recognise those people who don't have a diagnosis. We know, excuse me, that only 25% of our learning disabled patients are on our GP records as having a learning disability. We call that the register, excuse me. So we still need to be professionally curious about our autistic patients, our patients with mental illness, our patients with learning disability that might not have that on their records. Next slide, please. The next bit is the interface between our general practice surgeries, our primary care, and our hospitals, our secondary care, and we can be really proactive about that so that we can get the support that patients need. And one of the things that I wanted to highlight here is there's quite a lot going on in the digital world. So how we pick out bits of the referral forms or information that might be relevant to our administrative staff is a really big way. And actually we can follow people that might have been prone to not being brought, and we can make a bespoke arrangement around them from our appointment setters using artificial intelligence. Next slide, please. So there's lots of hospital mitigations we can do. If we know about reasonable adjustments, we can, for example, organise our scans, MRI or CT with some support. We have a pathway in some of our hospitals up here where if somebody needs a sedation, there's a pathway there where that is business as usual, and that can happen, and other things can happen at the same time, for example, vaccinations or bloods that might need doing. So we can take advantage of that opportunity to have other things like dental work done when someone's already sedated, with consent, obviously. Desensitization is really key, people getting used to the environment. We're very used to our GP or our hospital environments if that's where we work. Patients are really not, and we need to give them opportunities. I've put easy read appointment letters in there, and for me that also encompasses plain English. I had a mammography letter recently, it was 3 pages long.
We've lost your sound, Catherine.
I'm a health professional, it took me 3 times. Hello, can you hear me now?
Got you now, sorry, we lost you.
Okay, you didn't really need to hear about my mammography letter, but basically we send letters that are 18 plus in reading age, and our average reading age in our non-learning disability patients is 8 to 10. So we are missing a huge proportion of our patients with what we're sending out. We need to be routinely also translating it. So you'll have seen from Leeds, particularly the autism and learning disability sensory support bags that we can have in emergency departments or in our waiting rooms. And in North East North Cumbria now, if I request a CT scan or an MRI scan, I can actually add the reasonable adjustment. We have a little box where we can add the reasonable adjustment. So that's really moving that on. Next slide, please. So there's lots of things that secondary care, the hospitals can do. They can embed the learning and the reasonable adjustment digital flag and arrange and think about how their administration processes arrange flexibility of setting and appointments. And they can consider a pathway for the learning disability liaison nurses, for example, to routinely speak to people who are having a suspected cancer pathway referral. And I've already mentioned the sedation pathway, but I think that's really key, not just in planned care, but also in urgent care, for example, in an emergency. And I know that all of us are trying to embed the mandatory training. I really like the idea of an inclusion champion. All of these things need that special bit of effort to make sure that people feel included, and it's not really necessarily learning disability specific, but it would help everybody. Next slide, please. So I have really strongly disseminated this around our local voluntary and community agencies, thinking about dissemination of the materials to our patients and carers, thinking about empowerment of those patients and carers to ask for reasonable adjustments, as well as us being asking them, and also engaging with those wide ranges of organisations so that they can influence patients' ability to make a difference to their own world of health. Next slide, please. So there's lots of things happening next. We have actually updated our child not brought guidance to accommodate that 16 to 18 year age group, and also thinking about poverty proofing, making sure we're thinking about can our patients afford to get to this appointment, and also thinking about the reasonable adjustments. And there's a just on the right there is a clinic in Sunderland that have reasonably adjusted their respiratory clinic. They've lots of hints and tips about how to do that. So don't reinvent the wheel, it's already there. We're trying to roll out these approaches regionally and in fact nationally. Lots of I work with lots of learning disability GPs like me across the country, and we're all trying to disseminate this work. Next slide, please. So I'm very involved, and we are very involved in the Learning Disability Network with the health literacy, so that we think about those health literate approaches. I'm very much involved in the Core 20 Plus approaches about how we manage people who live in poverty and also have other conditions or other vulnerabilities. And we need to think about how we build services with reasonable adjustments in their specifications. And we will need to consider the ongoing evaluation of this work. In an ideal world, I would like the adult not brought code to never need to be used. Next slide, please.
2 minutes left. Thanks, Kathy.
So I'm going to finish on time. This is a miracle. I've never done it before. So in summary, patients without capacity or capability may not be able to bring themselves. We need to be professionally curious about that, and we need to think about adding the adult not brought code and mitigating it. We can now differentiate the two, and I think that's really important, and we are now counting the numbers. We can use reasonable adjustments easily to mitigate this across health and care. It is not systematically embedded yet. We know about it, we hear about it, but actually we need to now do it. And I think the reasonable adjustment flag will really help us with that. Next slide. I don't know whether we've got any time for any questions, but please email me if you want me to answer any of your questions. Thank you so much for inviting me.
Oh, thank you, Kathy. Yeah, no, we've disabled people's ability to ask any questions because the number of people, but we're making sure that people can contact you. And thank you so much for your professional curiosity. I think what started,
Pleasure.
you know, the idea of what started from, hang on, why aren't people getting here, to then making the connection between reasonable adjustments and what we can do to enable people to come is just so key. And this just needs to be rolled out nationally. And I guess, again, it's got asked for everybody in the call to be raising these issues with their ICP. There's a really good example in the work that you're doing, and we should be replicating it nationally. It's fantastic work. Thank you so much.
Thank you, Vicky.
I'm going to move
Thank
us
you,
on to
everyone.
our next speakers. We're on the last two now before lunch. Thank you, Kathy. So we are moving on to Robert and Pardip, who are going to be talking about the Clive Treacy Epilepsy Checklist, working together to improve outcomes. Is that your first slide up there?
It isn't. I think it'll be the next slide.
I think it probably is.
Oh, or the next one.
Keep going.
Keep going.
That looks better.
There we go. Hi.
Thank you. Welcome. Over to you. Thank you for
Good
joining us.
afternoon, everybody. I'm Robert Ferris. I'm the Regional Programme Director for Learning Disabilities, Autism and SEND for NHS England in the Midlands.
And hi, everybody. I'm Paddy Pindall. I'm the Deputy Programme Director working with Robert in the team in the Midlands.
And a bit like the reasonable adjustment element, we think this is a really impactful and game changer piece of work that we'd be really keen for people to look at how they take and adopt in their local systems. And I know we won't have any time for questions, but Pardeep and I will be absolutely delighted to be contacted afterwards to have to be able to share the Midlands work with you, but also to have any questions that you might have. So if you move on to the next slide. In the Midlands, we did a review of Into the Death of an individual called Clive Treacy. He was I'd never had the privilege of meeting him, but from what I've read about him and from the conversations that I've had with Elaine as his sister and also his parents, he was an amazing individual who had a learning disability and epilepsy. And on successive periods of time in his life, the NHS and wider care services failed him. And it particularly failed him in the provision of safe epilepsy cares for days, months and years leading up to his death. What we felt in the Midlands was that wasn't acceptable and we wanted to do something about it. So when we got the review outcomes, we really wanted to have a focus on how could we look at epilepsy for people with a learning disability and autism, and actually look at the commissioning guidance and the provision of care and how could we make a difference in that space. We know that 1 in 5 people with epilepsy have a learning disability, and epilepsy is the second highest comorbidity for people with a learning disability. So we worked with system partners and SUDEP Action to really create a movement for change. And the result of that was the publication in November 2022 of the Clive Treacy Safety Checklist and accompanying guidance, which we're going to talk to you about today. If you move on to the next slide. So what about the scale of this? So 47% of people with a learning disability who died in 2021 LEADER report had epilepsy. We know from the LEADER report that their life expectancy is 55 on average, which is 10 years less than people with a learning disability with other chronic conditions. So really significant disadvantage. We know that there is the second most frequently reported treatable cause of death in LEADER reviews. And autistic adults are 40 times more likely to die prematurely. And that alongside that have a really significant increase around sudden unexpected death from epilepsy. So the kind of the scale and the opportunity to make a difference is really quite significant. Move on to the next slide, please. So this is Clive. This is a painting he did himself. And alongside that is the summary findings from Clive's review. You can just see the cheekiness and the personality in Clive's face in terms of this. And this hangs in his mother's living room. So a real tribute to him. But a number of those recommendations related to the commissioning and the provision of care, particularly around the kind of the epilepsy side. But I'm going to hand over to Pardeep to talk you through some of the detail of that.
Thank you, Robert. So if we can just move on to the next slide, please. So as a direct result of the recommendations from the report that was the independent review that was done, there was quite a huge group that supported this, and this was in the form of an epilepsy advisory group in the Midlands. And when we look at the scale of this, it was a real body of national experts and regional leads, including an individual called Professor Rohit Shankar, who many of you may know from Cornwall Foundation Trust, but also the chair of the International League Against Epilepsy, SUDEP Action, Epilepsy Action, and Epilepsy Nurses Association. But it also included huge engagement from practitioners across primary care, secondary, community, and social care. So the level of engagement that we had in this programme of work, really leading and driving the improvements, was huge. And what you can see on the screen is just a couple of the quotes from some of the engagement that we had, where there were practitioners saying that they don't necessarily have the LD epilepsy background to challenge settings, and that seemed to be falling short. Even training, it did seem that some people didn't feel that they were adequately trained. And so on the basis of all of this engagement within the Midlands, we were able to form an improvement plan for epilepsy particularly. And it was based on 5 priority areas. One was very much around strategic planning to say, well, actually, what does good look like? We want to see good integrated services and support for people with epilepsy. Secondly, we want care commissioning and good oversight. And so for health and care commissioners, that they are adequately equipped to commission and oversee safe epilepsy care for people with learning disabilities and autism. Thirdly, it was around care provision, and it was looking at the care provision both within specialist hospitals and community care providers, and that individuals feel safe and that there's effective care for epilepsy care for individuals. The fourth was around health literacy, and it was to ensure that individuals who suffer with epilepsy, their families and carers, are adequately supported effectively, and that they understand and can effectively manage their epilepsy and the risks associated. And finally, there was a priority around epilepsy management. So really linking the opportunities with the annual health check, understanding the effectiveness of being able to review epilepsy as part of an individual's wider check. If we can move on to the next slide, please. So one of the direct results from the improvement plan, when we particularly looked at the health literacy, was the rollout of the My Life with Epilepsy programme, and the support and the guidance that was pulled together for carers. And this was produced by SUDEP Action. So it's a huge amount of resources that are available, and these were co-produced by experts by experience. A huge amount of work went into this. So if you haven't seen this, there's a scan, so you can scan the QR code within the slides when they're made available. Can move on to the next slide, please. The other element of the improvement plan was the Clive Treacy safety checklist. And this checklist, when it is used, needs to be done in conjunction with the guidance that was produced. And again, this was a huge piece of work that was commissioned, huge amount of engagement from experts by experience, but really pulled together a practical guide, which was done by SUDEP Action and Cornwall Foundation Trust, particularly for commissioners and care providers, and this covered specialist and community hospitals. And the real aim of this is to really improve the quality of epilepsy care that is delivered for people with learning disabilities and autism. So we can just move on to the next slide, please. So as an example, these are some of the themes from the guidance. I'm just going to quickly work through a couple of these. But with regards to epilepsy risk and sudden unexpected death in epilepsy mitigation and emergency response, what's really unique about each of these themes is that they are written from the person's perspective, as in, I would expect X. So as an example, for that one in particular, I want to ensure that I have up-to-date SUDEP CSER safety checklist in place that is periodically reviewed. These are my expectations if I have epilepsy for an individual with learning disabilities and autism. Secondly, we look at epilepsy care and monitoring. Simple things like having my medication that is monitored and up to date, that is person-centred as part of my epilepsy care plan. Co-development and family and voluntary sector involvement. So ensuring that my family members and advocates are involved in epilepsy-related decisions. Not a big ask, but actually really important to add these I statements. Transitioning between services, that I'm involved in transitioning planning in terms of the place and the method of transfer for me. Staff training, that staff who work with me have undertaken epilepsy training. So there's a huge amount of these I statements from within the checklist that really draw out what is important to that individual. It's really interesting to note as well for colleagues, and if anybody would like to find out about this, please get in touch. But Lincolnshire ICB are the first ICB nationally that are looking at implementing the SUDEP Action checklist within all of their GP practices across their patch. And this will be a game changer. It's a direct impact from their learning from Leader, and also looking at integrating the work that was done regionally into something that is more practical at a local level to benefit people with learning disabilities and autism within Lincolnshire. Thank you very much. I'm going to hand back to Robert now.
So next slide, please. So this is just some of the coverage and links that you'll be able to access around the things that we've talked through. And then our next slide is just our contact details, which we would be delighted to have contact from anybody in terms of interest, in terms of taking the work that we've done in the Midlands and making a difference to citizens in clinical practice. And finally, from us, a huge thank you for having us and for having us the opportunity to share the work that we've done.
Oh, thank you so much. That was, I've just used the word, used it a number of times, but game changer, you used a lot, didn't you, in scaling this up and this huge incidence that we're seeing in terms of people with epilepsy, and the review of people who have died through the Leader programme, and how key this is. And I know, certainly speaking from Sussex, this is one of the hardest areas we've managed to get anything off the ground around epilepsy. And it sounds like this might be a really good way of just starting the system to talk and say what should be in place. So it sounds like it's a very concrete, helpful starting point for many people on the call who may be thinking, where do I start with this now? Is that what you found?
Absolutely. And I think that's what Lincolnshire in particular are finding, that actually this gives some really practical things that enables very busy clinicians, particularly in primary care, to be able to make sense of what they're doing. They're holding a big day in February on World Epilepsy Day to really launch this with all of their general practitioners. But they've done a lot of work up to now around the kind of the ground foundation work of really getting people to understand it and starting to implement it in primary care. And I think in Leader, we're always looking for, I suppose, real practical opportunities that we can do to actually address some of the unjust differentials in outcomes and life expectancy. And I think actually this is one of those that could potentially shift the overall standardized mortality rates associated with epilepsy and learning disability, and alongside getting people to have really significantly better quality of life.
Thank you. Brilliantly put. Thank you so much. I'm going to move on to our next speaker. And I don't know if there's some unconscious process of work that we're doing total bowel management just before lunch, but we are. So welcome to Shiva Fuladinashta and Hannah Stahl, who are going to be talking about holistic bowel management, and it's everybody's business. Over to you.
Thank you very much. Thank you for inviting us today. So I'm Shiva. I'm the Learning Disability Pharmacist for East London Foundation Trust. And
I'm Hannah. I'm the Professional Development Lead Dietitian with a background in learning disabilities in the Trust as well.
So today we'll be talking to you about perhaps an unusual passion project of ours that we've been working on for the past year. And it's really about how do we manage constipation in our bowels. I do apologise, this is just before lunchtime, but it's an important topic nevertheless. Next slide, please. So why are we looking at constipation in our learning disability population? So this really came out of the Leder report in 2019, where they found that 23% of people that died prematurely were found to have chronic constipation being a contributing factor towards premature death. And about a third of those that did die prematurely were prescribed laxatives on repeat. We know that NHS England launched the Constipation Toolkit last year to try and address and raise awareness of constipation in our populations. And there have been some really good work done before all of this came out through the Poo Matters project, through Somerset and Dorset. But we were thinking about what we could do in our population in East London to try and address some of this. Next slide, please. So we started thinking about, why does someone with a learning disability have a higher risk of constipation? So we put some pictures up on the screen for you just to really summarize some of the thoughts that we had around this. So of course, as a pharmacist, I was thinking about medication and how we have a lot of medications that are quite constipating. We call them anticholinergic medications, but they might be pain medications, they might be medications that they take for side effects of antipsychotics, for example. But we know that there might be less ability to move around, there might be more of a sedentary lifestyle, and other neurological conditions might be contributing to that as well.
One of the most prominent risk factors that people with a learning disability might experience is lack of opportunity to go to the toilet frequently enough and comfortably in the right position. We did various pieces of training with nurses in neighbouring trusts, and this was feedback that they received, that people come in to secondary care settings with constipation that is very preventable and manageable in the community with the right opportunities to go to the toilet. We know that diet and fluid intake will be a huge factor in constipation management and prevalence, and what people are eating, how frequently, the quality of their diet will have a significant role to play.
Next slide, please.
So Shiva and I realised that we had more questions than answers we started building a working group looking at what are we doing about constipation in our various learning disability services. And we realised we actually need a bit more information about practice, and we weren't able to obtain that in the trust. So we went outside of the trust, looking at primary care settings, specifically GP practices in City and Hackney, Newham and Tower Hamlets, where we work. And we were looking at the prevalence of constipation and risk factors that may have come up. So we've just highlighted Tower Hamlets in yellow as having the highest prevalence of constipation amongst the learning disability population. We did a nice cross-check analysis. We defined constipation as somebody with a laxative prescription and somebody with a constipation risk factor, any of those that we mentioned in the previous slide. And it looks like those who were diagnosed with constipation also flagged using our definition. So that was quite helpful. We'll come to the actual definition of constipation later in the slideshow. But it was nice to see that that cross-check worked. There's a bar in red along the right-hand side, and that's to show that in primary care, practitioners weren't diagnosing the severity of constipation risk, the severity of learning disability. And so therefore it was hard for us to see if there was any bearings of LD severity and constipation. So we can't make any conclusions there. Should we move on to the next slide?
So we also looked at medication and what effect medications can have on relative constipation risk. So as you can see on this slide deck, the large majority of people that we'd flagged as being constipated were prescribed laxatives, so 83%. But then it raised the question of what is happening to the 17% that aren't prescribed laxatives. Do they have active constipation? Are their risks being managed? And then when you look at the no constipation risk, there is still 23%, so just under a quarter of the flagged patients don't have constipation recorded, but were prescribed laxatives. When you look at how that lays across our 3 boroughs in East London, it's fairly similar, but you'll see that City and Hackney perhaps overall has the lowest incidences of laxative and constipation, respectively, in terms of percentages, whereas Newham unfortunately has a much higher number. And then we also looked at medications that cause constipation, and what that really required was us to make a list of all the medications that we knew were constipating, and for our data team to kind of go in and try and correlate between those that were prescribed those medications, but also fit our definition of constipation. So as you can see, there's quite a large number of people that were on medications that can cause constipation, respectively, to those that didn't have a risk. Although the numbers look a lot higher, it's because of the proportion of people that fit that criteria. Next slide.
So this slide touches on the lifestyle factors that may be implicated with constipation. In the top graph, you can see that medications causing constipation are kind of way off the chart. So we zoomed in on the lifestyle factors in the bottom graph there, and you'll see that dysphagia and dietary limitations have a role to play or are potentially implicated. On the right graph, you'll see that the borough breakdown, we can see that there prominently are links between dysphagia and dietary limitations and constipation. It is worth noting there's often an overlap. You know, those suffering dysphagia also have dietary restrictions and fluid restrictions. So we imagine that that will have a significant part to play. We've also picked up on limited mobility, and we used a range of SNOMED codes to try and pick this up. We're not sure how well recorded some of these challenges are, but we did cast a wide net with the SNOMED codes. Next slide, please.
So we decided to have a look at annual health checks within these boroughs as well. And that was really over the past year and a half to get a better understanding and try and capture anyone that might not have had their annual health check for the year. As you can see, it's fairly even in terms of the number of people that have had constipation recorded in their annual health check for Tower Hamlets and Newham. But in City and Hackney, it seems that a large number of people aren't recorded as being constipated out of those that fit our constipation caseload. So it's quite interesting, and it raises the question of why is there such a discrepancy between our boroughs and the same ICB, and what are we going to do about it in terms of raising awareness with clinicians in primary care around this?
And
Next
how
slide.
can we make sure it's detected adequately at the annual health check and that there's an action taken? So yes, we've created a protocol together, really with a holistic view, encompassing pharmacy, understanding that pharmacy has a huge role to play, but also looking at therapeutic intervention at an earlier stage. We define constipation using the Rome 4 criteria. So it's less than 3 bowel motions a week or no more bowel motions than 3 days per week. Difficult to pass, maybe pushing or straining, or a sensation of incomplete evacuation. We recognise that lots of people with LD may not be able to tell us if they're having these symptoms, so it will really be about working with carers as well, who may be picking up these symptoms to help with an effective definition. And then we move on to the red flags. So there's, I'm sure a lot of you are aware, many other things that we could be looking for, like blood or mucus in stool, or abdominal pain, vomiting, overflow diarrhea, maybe a missed sign of constipation. It can be something different, but it can also present with constipation. And what we want to try and do is rule out any red flags to see if there are maybe risks of fecal impaction or that might require intervention from secondary care settings.
And it's a good opportunity to rule out or pick up things such as things we've seen in practice, such as service users that are having enemas given to them on a daily basis. And before we start giving lifestyle advice, medication advice, kind of jumping in and saying, okay, we need to deal with this more urgently or do more urgent referral in those cases.
Yeah, some of you may have worked with people who may smear species as well, and this could be a sign that they're in discomfort and they don't have the words to explain that. So that would be another red flag potentially. And then shall I move on to lifestyle advice, Shiva? Yeah, so one of the biggest things that could be so impactful is the correct toileting position. Now, we know that a lot of our service users may not have a normal stature, so it may be difficult to achieve, but there can be aids and supports to help with the right positioning. Frequent opportunities to go to the toilet is just a basic human right and something that we could be advocating for, and that's any practitioner, any lay person could support with that. Dietary advice, we've developed a suite of diet resources in easy read. We'd be happy to share them. But there should be lots of information about constipation management and first line advice, including things like prunes and kiwis, where there is evidence, probiotics and linseed, and of course, adequate fluid intake.
When we're thinking about medication, we're making sure that if someone is on a whole suite of medications, do they need to be on it, trying to optimize it, reduce any medication that might be contributing to the constipation, particularly if it's not needed anymore, and trying to make sure that they're on the right kind of laxative if they are prescribed laxatives, that they're drinking enough water to make the laxatives work well, such as with lactulose or with Movicol, and they're not on something that would cause them fecal impaction. If they're on opioids, for example, we're not giving them things like fibrogel. And then we're thinking about onwards from that, who we would need to refer them to if needed. So that might be our incontinence team or bowel cancer screening, if there are some red flags there, but also thinking about the skills of our multidisciplinary team. So our physiotherapists that are trained to give abdominal massage, maybe this is a good opportunity for them to come in and provide some holistic therapies that are outside of medication.
2 minutes remaining, thank you.
Next slide.
So we've done lots of work with different.
Sorry, can you press? Can you click it? I think it needs a.
Oh,
Oh
yes.
Yeah.
Yeah, we've done lots of partnership working. We've been holding various meetings with incontinence teams, bowel screening teams. We've worked with partners within ELFT and our learning disability service leads, as well as those outside of ELFT. We really want to wave the flag, raise awareness. We really think that this work is important, as we know that the risks are high for our service users. It's something that is very preventable in the community, and we would want to work together to try and reduce hospital admissions related to constipation, but also poor quality of life related to constipation.
Next slide, our last slide. So in summary, we are looking at lifestyle and also medication for constipation. And our hope moving forward is to develop a constipation protocol that we can use across primary and secondary care and work with our specialist providers as well. But yeah, thank you very much for listening to us.
Thank you. And you can be in touch. Our info is at the front slide.
And I think in the last slide.
Thank you both so much. That's again, it's just another example, isn't it, about some simple things make a really big difference. Yet this is a reason why people are unnecessarily dying. It's so important that we work together on this. And that stakeholder map said who needs to be involved to get this, protocol running. So thank you so much. It was really, really fantastic. So everybody, I'm going to move us now to lunch, you'll be pleased to know. So if everybody can be back at 1:45 for our next series of presentations. And thank you to all the speakers that have been with us this morning. It really is very inspiring and certainly making me think of all the things that we need to do in Sussex to make things better. So enjoy your lunch. Hope you have time to have it and you're not going to be doing your emails, and see you all at 1:45.
Okay, thank you. Well, welcome back, everyone. I can see that people are slowly coming back after their lunch. The numbers are going up bit by bit, not yet reached pre-lunch levels. So for those of you who missed the introduction in the morning, I'm Ashok Roy, and I'm co-chair of the Senate along with Viki, who chaired the morning session. So you have me this afternoon. And we've got a really exciting program for the afternoon. We had a very clinically driven content this morning, and it's slightly more to do with systems and delivery and stuff like that. So it's a perfect fit with the morning agenda. So it gives me great pleasure to welcome Karen Dodd, who until recently was a co-chair with me for the Senate, and who will introduce herself and talk about community learning disability teams. Hi, Karen, nice to see you. Over to you.
Hi, Ashok. Thank you very much for that introduction. So, as Ashok said, I'm Karen Dodd. I'm a consultant clinical psychologist. I've been retired a year now after 39 years working in the NHS in community learning disability services. I was co-chair of the Senate and with Ashok, and that was a pleasure. And we led the development of many guidance and position papers over the years. So today I've been asked to talk about the role of the community learning disability team. People could use different acronyms, but we're going to use CLDT today. And that's based on the guidance document that is available on the Senate website. So could I have the next slide, please? Okay, so just to emphasise to start with what the key role has been for many years of a community learning disability team, and that is to provide specialist healthcare to adults with learning disabilities where their needs can't be met by mainstream services alone. I think all of us would want people to try and use whatever mainstream service they can for their health, but often they need to come to a specialist team to help with them with either their physical or their mental health. And so we have a role in making sure that people get effective care and treatment. As Viv talked about this morning, we really emphasise the importance of a systems approach, and all CTBLD, CLDTs will work in collaboration with other professionals and agencies. But it's important to say here that the CLDTs do come in a whole variety of shapes and forms, and that is dependent on local service configuration and commissioning decisions. They may or may not include things like acute liaison nurses. They may or may not include the intensive support teams. They may include community forensic services. But so it's about that multidisciplinary working of key professionals together. And we need to make sure that we do have really good, effective models working in synergy with our intensive support teams and all our other teams to make sure that we increase community capacity and reduce undue reliance on inpatient services. There will always be a need, I think, for some inpatient services, but they should never be used as a fallback for the lack of community capacity. So if I could have the next slide, please. Okay, so managed to miss the date out on this slide. So the initial guidance on CLDTs was first published in 2015. And in my last year of work, we decided that actually it needed a good update. It had been 8 years since that reduced. Lots of things had happened since then. And we had a small working party made up of different professionals from the Senate who worked together to review and revise the document. And it was approved by the Senate and published on the Senate website in September 2023. And I've put the link to the address in this slide. When we looked at the document, some of the things we really needed to update was the fact that it was a very long document. We had a main document at that time and a summary, and I think that was too difficult for people. So we decided we needed a more concise document. We updated things like the key policy drivers and the research evidence, and then focused on some of the things that happened in the previous 8 years, including the fact there's now more specialist teams, the introduction of relationship centre care, which I'll talk about in a minute, making sure we get healthcare right, and thinking about what the core purpose of the teams are. So next slide. So I'm not going to go into these in detail, but these are some of the key policy drivers that were in place when we revised the document. And again, trying to make sure that we had things not just from NHS England, but from some of the other nations as well, and from other organisations. So we looked at a whole range of policy drivers that have driven the development and continued development of community learning disability teams. Next slide. We also looked at some of the recent research evidence. There's not a huge amount of evidence around that's written up about community learning disability teams, which is a shame, but this is what we could find. And we showed some of the evidence showed that the MDD approach is vital, that it will help in the reduction and appropriate use of psychotropic medication, and that links to the STOMP programme. The diagnosis of co-occurring conditions and health needs such as dementia, how CLDTs can support discharge, and also some of the wider roles of CLDTs, which often get forgotten, things like health promotion, health facilitation, health education, etc., etc. Next slide, please. So for me, in the document, what we wanted to try and put over was that good quality learning disability services are always based on strong community support services. And those need to be planned around the environment that the person is in, not about where they might be or could be or have been. And it focused on a relational approach, which looked at relationship-centred care, which incorporates many aspects of person-centred care, but doesn't just focus on the person, and primarily focuses on each person's needs and aspirations. So we are person-centred, but in the context of relational care. And we felt very strongly we needed to put a statement that this approach should be applied to everybody who comes into a CLDT, including those with very complex needs, because I think sometimes that gets forgotten with the complexity. And the services must be committed to achieving the right outcomes for people. So rights, inclusion, independence and choice. and that we need to somehow stick with people in spite of the difficulties experienced in meeting their needs. Sometimes it's quite easy to think, I can't do this anymore and I'm just going to give up. But actually, this is the person, this is their life, and we need to make sure that we stick with them to help them get the best life possible. And because it's a relational approach, the positive approach towards supporting people must always be accompanied by equal attention to the person's family and to their other carers and to the support services around them. So it is that relational approach that I'm going to talk about next. So next slide. So in learning disability services, we've always talked about person-centred care. But many people who know me know that I'm very committed to good dementia care. It's been my specialist interest all my career. And within the older adult services, there's much more scope to talking about relationship-centred care. And it really surprised me that that hasn't come really in an overt way into learning disability services as much as in older adult services. So there's been quite a lot of critique of person-centred care in older adult services. Because it only focuses on the person rather than thinking about the system and the relationships with the person, the family, their support staff, their systems. And so this slide hopefully tries to encapsulate that. And we've put it right at the beginning of the document to try and help people think about that move away from just focusing on the person, perhaps blaming the person for what's going on around them, to thinking about the wider support and system. And we all need to be working together. Next slide, please. So I'm not going to go through this slide in detail, but again, we put in what some of the principles under which CLDTs are working. These are not in any specific order, just how we managed to get them into a slide. So as you can see, the range of things that we try and do within a CLTD are hugely varied and wide to make sure that we are providing the best quality of care for people with a learning disability. Next slide. We also need to make sure that as a health, made primarily health teams, health services, we get the healthcare right for people. It's about adding your life to years and years to life, and that applies equally as much to people with learning disabilities and their families as much as the wider population and across the lifespan. I'm sure some of the things we've already heard about today in this conference we already know, but we know that on the whole, people with a learning disability generally have experienced poorer healthcare, have significant health inequalities, have higher rates of multimorbidity, and often have deaths, avoidable, preventable, and premature death. And we especially know that there's a concern for people with profound and multiple disabilities, who again likely have even more comorbidities and a poorer service offer. So we need to make sure that we get the healthcare right for everybody. Next slide, please. So in the document, we've tried to talk about the professional configuration of the teams, that they should be fully multidisciplinary teams with a full range of core registered health professionals working to the standards from both the HCPC and also their professional bodies. And we're really clear that those team members who are not a registered professional must be supervised by someone who is, with clear accountability and governance arrangements. We've talked about the range of people who might be in a team, but we haven't put in how many of each professional that a team should need, because that's impossible to do. It depends on the configuration locally, it depends on population numbers, it depends on needs, it depends on commissioning arrangements. We're forever being asked how many of this or how many of that. It's not a question you can answer, but you do need a critical mass. And you do need people, with a range of skills, ranging from newly qualified to senior clinicians. And it's really important that we have that, and that those senior leaders, clinical leaders, will be members of the CTPLD, so that they know what they're doing and they know what they're talking about. Next slide. So in the previous document, we had the 5 essential functions of a CLDT. We haven't changed those in this document. We have reordered them. And I'm just going to go through them very quickly because I've only got a couple of minutes left. So next slide, please. Function 1 is about the direct specialist clinical therapeutic support provided for people who've either got complex behavioural or health support needs. As we said before, it's all about working with people who cannot access mainstream services, even with reasonable adjustments. And so those individual specialist caseloads will include people with a whole range of different conditions. I think a lot of the NHS England documents really only talk about health and keeping people out of hospitals. They don't focus on some of all the other things that we do in a CLTD, which is a shame. So, you know, we'll work with people with complex communication, mental health difficulties, dementia, dysphagia, etc., etc., etc. And in order to work with those, then we'll work in very specialist ways with good assessments, good formulations, good care plans, thinking about the ways we work, either giving information, consultation, advice, support, therapy, etc. Function, next slide, please. Oh, sorry. So we need to be able to support people with the most complex needs for ongoing interventions. Now, in some teams, it's very difficult because the way they're configured means that people get short-term bits of treatment, but there are always going to be people who are required to have ongoing coordination from the team with options to step up and step down, matching the changing intensity of their health needs. Next slide, please. Function 2 is about crisis, and I know we've got Jenny coming to talk in a minute about intensive support teams. So again, I'm not going to go into detail, but we need to make sure that there are effective systems in place to proactively prevent crises, reactively manage crises, and proactively strategic plan and develop services to respond to crises. And it's really important that if the CLTT isn't doing it, there should be an intensive support team alongside to take some of those roles on, and I'm sure you'll hear more. We'll hear more later. Next slide, please. The next one is about enabling others to provide effective relationship-centered care. So this is about rights and inclusion and choice, reducing and shortening distress and suffering, making sure we give specialist advice to other people who provide the care, so we're not just the only ones in the care, we're working in that local multi-AG, multi-professional way that we want to do. Next slide.
2 minutes left, thanks, Catherine.
Then the fourth one is about positive access and response from mainstream. So this one is all about health promotion and health facilitation. So things like the role of acute liaison nurses, community and patient GP liaison nurses, etc., etc. I'm not going to go into this in any detail. And the next slide is about quality assurance. And I think often people forget that we can have a really strong role as the CTLD in quality assurance and strategic service development. And if your local services aren't making use of the CTLD doing that, they're not doing the best. And final slide. So just some closing comments. I think community teams, good community teams are absolutely essential. They need to have measurable and reportable aims and objectives. We need it structured in a way so we know that we can provide what we're being set out to do. We need to make sure we can deliver the 5 functions. We need to make sure that we've got effective workforce plans so that we've got the right people in place. And we need to proactively work with all other health and social care services so that people with a learning disability, their families and their carers receive a seamless and effective service. Thank you.
Thank you very much, Karen. This is a really important piece of work that we've been on this for some time now, and I hope it has it's picked up by services and commissioners all around. So thank you very much. Okay, so moving on, we now have the pleasure of introducing Heather Hanna, who comes from Northern Ireland, consultant child psychiatrist for children and adolescents, who will introduce herself and talk about every turn of the wheel is a revolution.
Thanks very much, Ashok. So I'm delighted to join you today. And as Ashok said, I'm a consultant child psychiatrist and clinical lead for Northern Ireland's first ID CAMS or CAMS ID service. And I'm going to talk about some of the lessons we learned along the way as we've set that service up over the last 10 years. So can we have the next slide, please? Equal access to CAMS. And we really wanted set the service up to ensure children and young people with intellectual disability had equal access to CAMS, nothing more, nothing less. This shouldn't be a revolutionary idea, but we know that our children experience health inequalities and barriers to accessing services when it comes to both their physical and mental health. About 1 in 40 children have an intellectual disability, And as many as half of them will experience a mental health condition during their childhood and adolescence. So they constitute a very significant proportion of the population who need access to CAMHS, and services should be tailored to meet their needs. It's about children and young people seeing the right people at the right time. It's fundamentally a rights-based issue about equal access to healthcare. So I'm probably going to be a little more philosophical than practical today. I hope you'll indulge me, and that you'll have some useful takeaway messages. And Karen has covered many of the practical aspects of how teams should be set up already. This painting is on the wall of a Belfast pub. It's one I've often found myself thinking about. Every turn of the wheel is a revolution, and it reminds me to keep going and celebrate the small victories. So on the next slide, it's a bit of a timeline of how services have developed in Northern Ireland, and we have a long way to go. 18 years ago, we had the Bamford Review of Mental Health and Learning Disability, widely regarded as one of the most comprehensive reviews of its kind across Europe. Its vision for people with ID was progressive and ambitious, even to today's reader. It included some early thinking about the development of specialist CAMHS teams. It was predicated on the imperative to close long-stay hospitals, and for children and young people at least, this was largely achieved by 2009. But community services have not developed in line with this. And over the next decade, there were multiple very damning reviews, all highlighting a need for improved access to mental health care and having a tiered system of therapeutic evidence-based services. 6 years ago, the Northern Ireland Children's Commissioner reported that access to specialist, multidisciplinary and therapeutic mental health services for this group of young people is wholly inadequate, and that the inequality in access should be immediately rectified. Sadly, 6 years later, where change has been limited. However, last year, Northern Ireland published a 10-year mental health strategy, and the importance of equal access to CAMHS was highlighted, and our team was included as an example of good practice. Subsequently, our commissioners have made a firm commitment to the development of CAMHS ID teams across the region. Next slide, please. So these are the areas I've been asked to talk about: how we work in systems and across NHS structures, the importance of team working and of meeting people's needs across the lifespan, the value of focusing on outcomes. These are all very relevant to how we work, and foundational to all of this is the principle of equal access to CAMHS. Often we have to work across systems and structures to remove barriers to children and young people accessing timely evidence-based care. My experience previously that the professionals were organised like a row of houses, with families having to knock on a lot of doors to get to the right one, or not finding the right one because a multidisciplinary approach was needed, and we wanted to make sure there was no wrong front door. Next slide, please. But before I talk about each of those areas, I'll just say a little bit about our context. Northern Ireland, hopefully you can see it on the right there. We have a population of about 1.8 million. We've had fully integrated health and social care since before I was born. And essentially, we like to keep things simple. Northern Ireland is divided into 5 geographical areas with trusts responsible for all of health and social care. This has many advantages, but it does mean that CAMHS is a very small fish in a very big pond. I work in the Southern Trust, the pink one. It's a border county with areas of urban deprivation and rural isolation side by side, and like much of our country, very impacted by the legacy of the Troubles. Within our trust, as you can see on the left, CAMHS ID is fully integrated within wider CAMHS. CAMHS sits within a division called Child Health and Disability, so alongside services like Community Peds and Children with Disability Social Care, and that sits within wider Children and Young People's Social Services, Children and Young People's Services altogether, including the acute hospital. So ultimately, that structure creates opportunities to meet children's needs very effectively. However, it's a system under insurmountable pressure, and major reforms are likely. The retraction of services like Community Peds means more children are coming to our front door. And then CAMHS in Northern Ireland is structured in a step care system, which you can see in the middle, similar to the tiers in an English system, but intended to be very flexible and responsive to the needs of the child. And stepping up and down, the system moves to the child more than the child being passed around the system. And when it works well, it's great. We intentionally focus our resources on targeted early intervention and specialist intervention, but we can flex up when we need to in response to crisis. Next slide, please. So how do we work? Compared to CAMS, I like to say we're the same when it suits me, and then when it suits me, I like to say we're different. I'll let you read through the slide. And this is what I mean by equal is not the same. This is about reasonable adjustments and more. Assessment can sometimes take months. A sudden change in behaviour can be anything from a sore toe to a schizophrenic illness. We cannot expect to sit in clinics and talk our way through the difficulties our children experience. We cannot meet their mental health needs without addressing their physical health needs, and so on. Next slide, please. So this is our vision. We journey with children, young people and their families, giving hope by working for and with the child to ensure the best possible quality of life. So the next slide is about system partnerships. We said we've worked in teams, but the needs of our children can only be met by a multidisciplinary agency approach. Being part of a single agency with social services allows us to work collaboratively with children with disability teams, and often that simply means things like regular planning meetings or developing joint safety plans. But sometimes, however, our role is to bring challenge and solution across the wider system. It's not so much about fighting the system, but unlocking its potential. Systems, by definition, are set up for self-preservation, and we need people to step outside that and work to meet the needs of the child and do the right thing. We know that our children and young people can become very distressed, that people can find that very challenging and become very overwhelmed when trying to respond. And people fall back on automatic ways of thinking, which in the past has led to institutionalization, exclusion from school, a view that only a psychiatrist or medication can fix the problem, reliance on restrictive practice. People can present all this as complex needs, health and safety concerns or resource deficits, but maybe there's still an unspoken view that institutional care is necessary. Our role is to bring a different perspective, a detailed assessment that allows people to see the child differently, a shared plan that is positive in its approach. One good meeting can be the start of meaningful change. Next slide, please. So as well as systems, we need to help children negotiate structures. When a child is presenting with very high levels of distress behaviour, this may or may not be because of a mental health problem. However, we usually have a role in assessment and trying to move things forward using a positive support framework. We often reframe complex needs as fundamental needs and make sure everyone is working together to meet them. Sometimes finding the one simple thing can make all the difference in a child's life. Convincing a community paediatrician to treat their constipation, or understanding that the use of time out in school has become traumatic. Sometimes it's many things at the same time, and as Karen said, you need to stick with it and bring everyone together to keep working through things until we see positive change. Does this really need a CAMS service? Sadly, sometimes yes, because no one else has worked it out. And we need to relentlessly focus on understanding and meeting the child's needs. Next slide, please. So how do we work as a team, or what does our team look like? CAMS ID practitioners are drawn from a range of professional backgrounds, and we have a good mix as well as significant gaps. The skills to work in the ways I'm describing must blend with clinical acumen and a natural ability to work with our children and young people. There isn't a cohort of CAMS ID ready clinicians, and we essentially must grow our own. Clinical governance is essential to ensure continual improvement and prevent idiosyncratic or unhelpful practice slipping in. It's been said that revolution is exhausting, and holding on to shared values enables people to work together effectively. Distributing responsibility for managing risk across the team ensures people don't become defensive or avoidant in their practice. And there's no doubt that people can burn out, and one person can impact on the morale of the whole team. So this requires careful and continuous attention. Next slide, please. We're often part of a young person's journey into adulthood, and we see services start to fall away, unfortunately, from about the age of 14. Our transitions pathway aims to pass on critical knowledge and make sure that young people reach a period of stability before they move on from our service. However, often because they've had a good outcome and things are stable, it means that they don't meet the threshold for adult therapeutic services. That's a positive in a way, but ideally we would like people to get to know them when they're doing well so they can respond quickly and effectively if things change. Next slide, please. Finally, to outcomes, you maybe can't see that. We've had no inpatient admissions for 5 years, no out of area placements for 10 years, and a reduced use of medication. I'm not sure we had a focus on high level outcomes from the outset of our service, but time has certainly demonstrated that we add value in terms of the things commissioners focus on. A significantly reduced reliance on inpatient admissions and out of area placements. We've consistently received positive feedback from parents about how much they value seeing their children happy and healthy again, despite things having felt very desperate. Parents value a child-centered approach and a responsive service, and consistently feedback tells us they also value clinical expertise. There's an important role for inpatient services for children and young people with an intellectual disability. Our motto is in the community where possible and in hospital when necessary. Preventing admissions requires us to step up and provide wraparound support. We might be in the child's school every day. Occasionally we've been there to put them to bed at night. This is difficult, but worthwhile work. And when you're at the crossroads, one turn of the wheel can set a new direction of travel. Early in my role, I was asked to sign a form seeking a placement in a unit in England for a young man. Our system requires that consultants sign off social care placements. This placement was considered inevitable, the only option. I said no. People literally nearly fell off their seats in the meeting. But looking back now, it was clearly the beginning of doing things differently. We brought a virtual team around the child, including a teacher and a key worker from his local residential facility, and met fortnightly for 2 years to have a coordinated therapeutic approach. He did so well that he actually was discharged completely from CAMHS, on no medication, attending school, having regular family contact, and even rock climbing in his local community. When you get the right people in the right time and a virtual team around the child, you can always make a difference. Next slide, please. So just to conclude, vision and values must inform everything we do. Helping people see and do differently is part of our job. Doing the work is easier in the long run than not doing it, and we can improve outcomes for all children and young people. So final slide, thank you. Please take some time to watch our video. We decided that our children and young people could tell their own story and illustrate the need for our service much better than we could. We've used this video at multiple events, and I've seen it reduce commissioners to tears, so it's worth a watch. Thank you for your time today, and I'm happy to be contacted if anyone would like to know more. Thank you.
Oh, thank you, Heather. I can't wait to look at your slides again and plagiarize them ruthlessly. Of course, crediting you for them. So great work. Fantastic. Thank you. That's really nice. Okay. You've got Heather's contacts there, so please contact her. I certainly will. Our next presentation is from Jenny Shaw, who's going to talk about intensive support teams, vital cog in the wheel. So over to you, Jenny, if you introduce yourself and your talk.
Thanks, Ashok. Hi, everyone. So I'm Jenny. I'm a clinical psychologist by background, and I am the lead for an intensive support team in the London Borough of Southwark. And I'm also the chair of the National Network of Intensive Support Teams. Next slide, please. So most of you probably know, but intensive support teams are sometimes called enhanced teams, and they kind of came out of the Transforming Care agenda, although some did exist prior to that. And they were recommended and commissioned in response to Transforming Care, and kind of this is a little bit of a diagram that's come from the National Service Model. So it sort of outlines the need to kind of recommission services for the top of the pyramid, so people at risk of admission, and inpatient services. So although it doesn't state exactly what should be commissioned, it says that things should be kind of looking differently to how they used to. Next slide, please. So in practice, intensive support teams are usually small specialist services who see a small number of people. However, those people they do see present with complex difficulties and behaviours that others in the system are finding it difficult to manage and support. So we know that this is a group of people who often end up being admitted inappropriately and can be difficult to discharge once they are admitted. We also know that they can be subject to high levels of restrictions and restraint, whether in inpatient services or in the community. And they can also have frequent placement breakdowns and increased prevalence of trauma. So commissioning care and support for this group can be costly in terms of admissions, but high staffing levels, things like that. So ISTs don't just prevent admissions, but they also prevent placement breakdowns. They also increase quality of life, reduce behaviours of concern, reduce restrictive practices, increase family satisfaction, and also generate financial savings. So they're not a kind of purely just crisis team preventing admissions. They do lots of different things associated. Next slide, please. So the National IST Network was something that I set up a couple of years ago, and it is a group of IST leads and senior clinicians. We have just over 100 services signed up now across England and Wales. We don't have any from Scotland or Northern Ireland as of yet, but we do have a few kind of links to CLDTs in Scotland. We meet bi-monthly, and the main kind of purposes of the group are to share knowledge and practice, to discuss issues and dilemmas that are coming up for ISTs, to share any developments locally or nationally, and consider any challenges that people might be facing. And often we're finding it's similar things that are coming up nationally for these services. We also discuss research and gaps in research, and we've recently started to gather some information and share data. So that's what I'm going to kind of talk about for the rest of my time now, some of the data that we've gathered from the national picture. Next slide. So as I said, the national service model says that every area is different, and the kind of services should meet local need. So they will be slightly different. However, it does say there needs to be some national consistency in what services look like based on established best practice. However, research, information shared in the network, and kind of an initial scoping survey we did in 2021 indicated that there is little consistency in ISTs nationally, and some areas, in fact, quite a lot of areas, still don't even have an IST service available. Next slide, please. So we as a group set out to gather a bit more information and outline a position statement. And we wanted to understand kind of the landscape of ISTs currently. We wanted to develop a kind of a picture of what best practice is in ISTs, because the guidance says that services should be designed around best practice, but these are quite new services, so I don't think we had a good sense of what that was. We wanted to share challenges and kind of share this learning a bit more widely so that it could influence commissioning. So we did a survey of members. We had 26 services responded. And you can see from the map that the services that responded are quite spread out across England and Wales. So although it wasn't a big number, it covered quite a big geographical size. We also undertook a survey of carers who've used ISTs via the Challenging Behaviour Foundation and had 9 responses. So we're very grateful to CBF for helping us with that. And we also did a bit of a literature review as well. Next slide, please. So landscape of ISTs is kind of the first area we looked at. Next slide. So in terms of when services were developed, cumulatively kind of services are still growing and they're still being developed to date. There were 23% of the services that we surveyed were developed in 2014. So that's in response directly to the national service model and building the right support. So as we would have expected, most services have been set up post 2014 and they're still growing to date. And I know of a few that have just been set up in the past sort of 6 to 12 months. So it's still an area of development. Next slide, please. So we had 65% of respondents were from adult LD ISTs, 20% children's ISTs, and the rest were lifelong. 92% of the services were funded by health or the ICB. Some ISTs have a separate forensic LD provision locally, some don't. And there's really a wide variation in team makeup. But generally, it was either smaller teams made up of quite highly banded kind of senior specialist clinicians offering kind of an expertise, or larger crisis teams with some highly banded kind of specialist workers, but a kind of larger population of those kind of more lower banded support staff. And the kind of the smaller teams tended to not have those kind of lower banded support staff. And then out of hours commissioning, so out of the kind of 9 to 5 Monday to Friday was so great in variation. We couldn't really even analyze it, to be honest. It was just so varied. Next slide, thank you. So you can see that in terms of, you've got on the side here, the population area, and then at the bottom, you've got whole-time equivalents in the service. So that there is a positive correlation that the more kind of people live in an area, the more whole-time equivalents that service has. So that's a good. But as you can see, there are some really big anomalies. So there's some services who don't see that many people but have lots of staff, and some services that are kind of for smaller populations but have hardly any staff. So it's by no means, as Karen was saying, there is quite a lot of difference between different areas. Next slide. So all the ISTs had different timescales for work, which impacted on measuring outcomes. So basically, if you discharge someone purely after the crisis, after they've kind of settled down, then you're not going to see the same long-term changes as maybe services who keep people open a bit longer and really work with them until the behaviours have perhaps reduced, a lot or gone away altogether. Referral routes indicated that ISTs are mostly positioned as secondary or tertiary services. So most referrals come from the CLDT or MHLD or CAMS, and they kind of step up into IST when things get quite tricky, and then the IST steps back down. And that was a good model that we found that is working quite well. So IST success is basically really reliant on that service being well funded and well kind of provisioned, so that the right people are being stepped up into the IST. Next slide, please. So in terms of outcomes, I'm not going to go through these, but you can see these are the main outcomes that ISTs are kind of seeing. And like I said, not just reducing hospital admissions, but there's lots of other outcomes that we see as well. And these are kind of rooted in evidence research and also our survey data. Next slide. So I just wanted to include the service model so you can see where ISTs fit. So they're over in the kind of principal 7 to 8 specialist services. And as I said, they're kind of a step up from the CLDT or the CAM service for children. But they're very much positioned within a whole set of services, and their success is really rooted in well-provisioned service around them. So if you go to the next slide, I've tried to put this together to kind of show that it's not just a stepped care model that people get to IST when they're in crisis and then maybe kind of step back down. But it's also IST success is really reliant on some of those things underneath, those strong foundations being present. So particularly things like appropriate housing, having good respite, kind of people getting access to their annual health check. All of those services and aspects of someone's network need to be in place in order for ISTs to work effectively, because otherwise people would just come to IST and they'd be overwhelmed with lots and lots of people in crisis. So as I said, one of the things we tried to do is look at best practice. So these kind of things in the boxes around this triangle are some of our areas of best practice that we found. So we looked at having ring fence provision so that the service could be flexible, dynamic, and intensive when it needed to be, so that time is protected in that service. Like Karen said, having access to a full, highly skilled MDT was really important in ISTs as well. And having a layer of expertise around kind of decision making was particularly important. Working in partnership, offering trauma-informed systemic PBS and focusing on capable environments was really important. And it was really important that the service was linked to LD services, including social care. So having a pathway to step cases up and down as needed was really important. And as I say, that greatly contributed to the success of IST work. Next slide, please. So in terms of challenges to best practice, there were three main things. The first thing was that not every area in the country has an IST. And that means or kind of even if there is an IST, they don't necessarily have all the elements they need to be as effective as possible. Or sometimes the service was felt to be too small to kind of deal with the demand that they were under. So we're hoping that when we publish the position statement, that will help guide the commissioning of ISTs going forward. The two other big challenges were not having access to good quality community care provision, which I think will be familiar to everybody. Getting good quality community care and support is tricky. And then the other one was joint working across sectors. So for example, joint working across health and social care can sometimes be difficult due to barriers that are in place there. And my final kind of slide next. So we are now looking to publish this position statement that we've kind of come up with and the survey findings. And our next steps as a network are we're very keen to engage with and open up discussions around this best practice and specifically around overcoming these challenges that I mentioned so that, you know, everyone with a learning disability who needs access to an IST gets access to a good quality IST. We're hoping to set up a research subgroup and, you know, if you know of any ISTs that aren't part of the network, please do kind of point them my way and feel free to kind of get people to get in touch with me. My email address is just on the next slide. But thank you, everyone.
Thank you, Jenny. That was really good to hear about this this important chunk of the service, which often gets misunderstood and misused because people have a sort of fantasy about what an IST can do, and they often pitch it wrong without relying on the joint working aspect of it. So thank you for that, and your email address is there. So please, people, if any of you here know of an IST that's not joined the network, please make sure it happens. Thank you, Jenny. The next slot is being done by Nick Crosby as a solo act, I understand. And it's called Small Supports, Big Differences, Better Lives. So I'll let Nick introduce himself and give us the talk. Over to you, Nick. Where are you?
Here.
Ah, good.
Yeah.
Over to you then.
Thank you, Ashok. I guess this program is in a sense tackling what Jenny was just mentioning about quality community care provision for people. So I'm got 15 minutes just to briefly introduce the Small Supports Program at NDTI. It's a program of work that's funded by NHS England, the Learning Disabilities and Autism team. We are a partnership with 3 small support organisations called Positive Support for You up in Middlesbrough, Beyond Limits down in Plymouth, and Sea Change, who you'll hear a bit more about in a minute, up in Glasgow. And we've been working for the last 2 to 3 years developing new small support organisations across the country. Next slide, please. So I guess the first thing is that small supports aren't new. This is the Small Supports Programme grew out of the development of 2 or 3 small organisations that supported people as they moved out of Lennox Castle, a long-stay institution on the outskirts of Glasgow in the 1990s. As they moved over 1,000 people out, there were a number of people who needed much more intensive support to live in the community, and there weren't the support organisations there. So they set up one called Inclusion Glasgow, and then a second called Sea Change, and then a third called Partners for Inclusion, who their structure and their way of working very much influences how we work today. In fact, some of the things that they do back then are exactly the same as what we're doing now. I guess that's the first thing, is this is a program of work that's based on a lot of history. So Sea Change have been around for 22 years, Beyond Limits for the last 14, Positive Support for You for another 14 years. So the stories and the learning that we're sharing, although we're talking about setting up new organisations, has a basis in history. I'll be sharing the slides will be available to share, and there's links to all sorts of information within the slides, as you'll see as we go through this. Next slide, please. So I guess people are wondering, what's a small support organisation? In simplest terms, it's an organisation that's made a commitment to stay small and stay local. So those first organisations said they'd never support more than 50. And when they did get to 50 people, they set up a new one, hence there's 3 up in Glasgow. For us and the organisations we're working alongside, we're more likely to be working with organisations that are supporting 25 or 30 people. And that's reflected also in the management structure. It's a very flat management structure. The director of the organisations knows everybody who's been supported, knows all the support teams, and that in itself is a real factor of safety for that person, because everybody knows how to support and knows the person's story, and there's no kind of gap between management structures and the actual direct support work. At the heart of small support organisations is the voice of the person. Every single person who's supported by a small support organisation, the first thing that happens is the organisation meets with the person and they sit down and they start writing out that person's story. They start finding out about what works for them, what doesn't work. They find out about family history, important people in their lives. It draws on some of the person-centred methodology. We would call it individual service design, but at the heart of it is the voice of the person and their loved ones. This fosters then the building of connection. So a team of people are recruited to support that person. They say they're matched. It's where people are matched not on the number of hours of care work they can do a week, but on shared interests. So if you look on the Sea Change Facebook page, you'll see adverts for joining DJ Nick because he wants to spin some discs, or you'd be able to join Angus because he has a love of bagpipes, or you'd be able to go around fairgrounds with Ross. It's all about building relationships that are on shared interests and shared likes. It's not about simply being there as a paid person, and that's reflected right the way through. Those relationships that are built with the support team and the person are backed up across the organisation. Small supports organisations say we never walk away, and they don't. The only time that support's ever ended from a small support organisation has been at the choice of the person, not the organisation. And that can even be on the most difficult of times. So that has been times where people have been back into inpatient and the team have been there to meet them when they come out. There's been one instance where somebody's been in prison. The team were there to meet them when they came out. It's all about sticking with them. If they're going to invest in these relationships, then that's how they're going to be able to hold this person to have a really good life. The last part of that, it says a home of my own. It's a supported living model. So the home and the support that's provided is separate. The person keeps the home, but can choose to change support. It's that person's home, just like it would be for any of us. It's our home, and it's not about somebody else having control over our home in so many ways. The key words for us, and to quote Dave from Positive Support from You in Middlesbrough, it's a relentless focus on the person. There is no compromise. And the moment you compromise on the support that you're providing and what works for that person is the moment you start to fail. Next slide, please. There's a number of different stories. People always want to hear stories about what it means for people. When the slides come round, I'd invite you to listen to Mark. Mark's supported by a new small support organisation in Leeds called Unique Support Solutions, and Mark will tell you about the changes in his life over the last 12 months since he came out of an institution where he'd been for 20 years. I put Huey on the side there because Huey actually was one of the first people supported to move out of Lennox Castle into the support offered by a small support organisation. I interviewed Huey, enjoyed his broad Glaswegian accent, and we spoke about how his life's changed since he moved out. He used to have 24/7 support. He sees his support worker for an hour a week. He's got a girlfriend, he's got his own flat, he's got his own life. He's a much happier man in his own words. The last selection of stories is our small supports library. This is a growing selection of testimony and stories from people and their family members in their own words. There's video, there's audio, and there's some text alongside each story, and invite you to go and hear from people directly exactly what it's meant for them being supported by a small support organisation. Next slide, please. I think it's clear that it's not just about it working for people, although as you'll see in these quotes here from a recent evaluation of working leads, people talk about very ordinary changes in their life, but those ordinary changes are incredibly valuable to them. So they talk about having their own key. They all talk about being able to get the bus to see their mum. They talk about it being quiet, being able to cook their own food and not being interrupted. People really value that kind of feeling of having their own space and their own people. Down the side, there's clicks to other pieces of evidence, including an evaluation of the impact of actually investing in a small support organisation, thinking about commissioners, and looking at what happens for every pound they invest into a small support organisation, with the idea that actually small support organisations are rooted in local communities, so all the money flows into that local community, whereas for bigger organisations who may not be centred in that community, a good chunk of that money will shift out of the local economy before it touches the ground. The workforce document looks at the experiences around recruitment and retention. Retention does seem to be a strength at small supports. You'll see a number of people who are interviewed in that piece of evaluation talking about belonging to an organisation and working for a person. And it's a very different language than you encounter when you often talk to people from other support providers. And I put a link up there to an external paper called Listening to the Experts by Alexis Quinn, Alicia Woods, Kerry Lodge, and Baroness Sheila Hollins, which looks at the importance of listening to experts. And we'd be saying with small supports, that's exactly how we root all our work. We listen to the person because they are the expert. Next slide, please. And most recently, we've published a report called The Deep Dive into the Small Support Experience in Plymouth. Beyond Limits, one of our partners, has been going for the last 14 years. We gathered a group of 9 stories from 9 people they support. We documented the stories, and then we looked at the changes in their well-being over time, the reduction in incidents that one or more of them might experience over a year. And we set some financial values against those. The methodology for that is set out in the report. I'm not an economist. I wasn't the one who did the reporting, so I won't hope to explain how it works. But there's some very clear and compelling evidence that it's not simply the fact that people are having a much better life. We have to acknowledge that finance is dictating a great deal of what we are able to do at the moment. But when you take a small supports model, people have better lives, and the impact across the system is very, very clear. And there's a reduction in costs for the actual support. So people are welcome to have a look at the report. You'll note there's a little, I haven't taken it off these slides because I sent them earlier in the week. We've just had a lunchtime event, which I wasn't here earlier. So you won't be able to join the one on the 17th of October, but the recording will be up shortly. And that's work with Mike, who did the economic analysis for the report. And last slide, please. So it's a whistle-stop tour. I guess the passion for me and the whole team at NDTI and our partners is that we're really clear that this actually works. The importance of the report around Plymouth is it shows that it does not just work for people, which we've known for a long time, but actually economically it makes a very strong case to be a key part of any local support, development support. And we'd hope, going back to the point made in the previous presentation, that this is seen as one of the ways of tackling the lack of quality and dependable local community care provision. Thank you, Ashok.
Thank you, Nick. You finished a minute early, so can I just ask you then, the first person to be questioned today, that you mentioned some pounds and pence there, and I was wondering whether you've been able to use that argument to attract further investment in this model.
That's not my alarm. I think it was an alarm saying, Nick, be careful what you say. No, it wasn't. I think we published the report back in September. We're starting to get feedback from what it's saying. We haven't actually had the data all in one place at one time. This report actually brings together a huge amount of information and makes the case in a way that we've not actually been able to as a programme, other than drawing on different bits of evidence. I think people are starting to take notice of it, and we hope very much that that people understand it's not simply a reduction in care costs, it's actually the impact across the police service, the ambulance, the GPs, the MDTs, the community learning disability teams, that this has is more than just a tweak. It's actually a substantial difference.
Thank you for that, Nick. I hope we talk much more about small supports in the months and years ahead. Thank you very much. Okay, so we have come to the afternoon break. So we'll have a drink and come back at 3 o'clock on the dot so we can finish on time. Thank you all very much. See you in 15 minutes. So it's gone 3 o'clock. For those of you who have joined late, I'm Ashok Roy. I'm co-chair of the Senate along with Viki Baker. And we have now come to the last chunk of presentations, but really interesting ones actually. And so it's my great pleasure to invite Bethany Kruger, who comes from Wales, to talk about the co-production journey. So I'll let you introduce yourself fully, Bethany, and give us your talk now.
Thank you all. I'm trying to undo my video and now that's not working. Yes, it is now working. Check the sound, but I didn't check the video.
There you are. Perfect.
Yeah. Thank you. So yeah, my name is Bethany Kruger. I'm from Wales. I'm part of the Learning Disability Programme, or the team, which is part of Improvement Cymru, which is now recently been changed to Quality and Safety Improvement Cymru. And to kind of make it relevant, we're equivalent to Improvement England. So we have the same remit really, and I'll go into a bit of that in a moment. The aim of us, as you said, we sit in the improvement team. We are mainly clinicians by background, and many of us have all got learning disability backgrounds. And our service, or the Improvement Cymru, is aimed to improving services on a national basis. But for our particular programme, we were set up several years ago to improve the lives and to address the health inequalities of people with learning disability and the premature and avoidable deaths. And we were, our latest directives, or our health outcomes, are based on the Learning Disability Delivery Implementation Plan and the Learning Disability Strategic Action Plan. So we got several specific outcomes, health outcomes, that we need to deliver on that, which is through that programme. The work is split into 4 areas. I need to give the context to tell you some of our journey. The work is split into 4 areas. We look at physical health. So when people are accessing acute and secondary care, what does that mean? Are they having that good health service? Physical health, as we know, that's not necessarily the case. Then we also have got a work stream that looks at specialist services. So we're looking at learning disability services across Wales within each of the health boards. And we have health boards opposed to trusts as well. And we have a work stream look at children and young people. We did, but we no longer have a work stream look on the health equalities framework. So now that's now embedded within the rest of our work streams. So we are due to end next in March, but with a plan of a new programme to look like. But altogether, although the team is looking at improvement, the reality, we look at service redesign, we look at service delivery, and we look at lots of projects from annual health checks to larger projects, just as long stay hospitals. So we have quite a large remit of everything that's to do with people with learning disability in their lives, really. So and what's really important, the implementation plan, the strategic plan was developed from a co-production perspective. So within Wales, we have a learning disability ministerial advisory group that advises the Welsh Government on issues to do with learning disability. So the plan has been devised by this group in conjunction with third-party and voluntary area services, Learning Disability Wales and MenCap, and quite a few local services as well, and charities and third sector groups. So we come from a place, so the initial development is very much a co-production. Could we have the next slide, please? So we've been, as I say, set up for several years before we were a different programme, Improving Lives. But what was really recognised to us, or what we recognised quite quickly, that actually, despite us being the initial development was a co-production approach, us as a service, or us as a programme, we were really struggling to continue that consistent co-production theme throughout. One, because of the size of the projects. Two, because of the barriers, because we were working right across local services with health boards, social care, third sector, people themselves, families. So, but we were very aware that actually we were not consistent in our different pieces of work, on our programmes or our projects or activities, that actually we weren't doing this truly throughout this. So we kind of set ourselves a task to increase the use of co-production in our improvement projects and activities. We had lots of discussions about what we should do and where should we go, but it's actually time to, we thought we need to know what we are doing. We need to make sure our own programme is doing the right things before we start asking others and expecting others to do that. Next slide, please. So the question is, we recognise that, and that's good, but what do we do? What did we do about it? So, as we said, some of the barriers were within the team was we all had a very different understanding what co-production meant to us. We had some of us who had been in previous roles and positions that co-production was very central, and others who understood it but never actually embedded it truly. And I suppose, like lots of other people, misunderstood what it meant and was quite fearful of what that meant. And there was lots of worries about, due to the size of some of our projects. And we have dates for deliverables as well, whether we could achieve our Welsh Government's objectives. So there was lots of discussions about what is doable, what was not doable, and what was expected, really. Despite this, mind, when the team first started, because I said this is the second programme, the first programme when we first set up, we had developed a mission statement which did include co-production, and that was very much the heart of the programme from the day we were instigated. So as you can see, we will work with our partners to create sustainable improvement in health and well-being of people with learning disability. And we spoke about authentic co-production rather than just using terminology. But we were very aware that despite us being set up for several years and our programme has changed, that actually we stood that we were still not very good at it. And the previous employments I had of legal positions, it was very core to my kind of working practices. So I was quite an advocate and quite loud within the team, saying, look, we're not quite there yet. We need to do this better. Despite that, despite our programme, we do have very good links with our third sectors, with our family and carers. I don't want people to think that that never happened. And we have lots of our pieces of work we do co-produce, or the different elements of co-production. And we regularly meet with the Learning Disability Consortium in Wales, which is where all the third sector parties meet, and we are a member of that. So it's not that we didn't have our contacts, it was perhaps we didn't quite know how to do it, or where should we start, or which elements should we do. And again, having that different understanding and different skill set across the team was making it a bit harder. So next slide, please. So what did we do? You know, we had to make sure our team was kind of skilled and understanding first. So we basically did an improvement project on ourselves, I suppose. We went back to basics, and we needed to understand what our team understood and where our project was with the different elements of this. So we went back and we benchmarked where we was. And one of the things that came out quite quickly is actually that the different understanding meant we had different skill sets. So we asked Co-Production Network for Wales to come in and provide some training for the team. So we had a 2 full day training for the team, and this was their wheel, or this is the wheel that actually was part of the training. And I put this in because for us as a team is really quite powerful. We are quite visual learners, I think the team is, and this kind of demonstrated, I think some individuals worried that we know our pieces of work can be quite complex. So sometimes we are delivering policy, sometimes we're developing strategy, and sometimes we're doing a very small improvement project locally. So at times it was quite overwhelming for some of the team to kind of think of how we can fit co-production in, given that the objectives or deliverables was already set. So sometimes, as we know from co-production, ideally we want the people themselves to identify the problems, and then as a group together we go through that process to find the solution and then to deliver the solution. But we were in a very different position because we were asked to increase the uptake of annual health checks there to address restricted practices. So some of our asks are quite vague and some of them are very clear. So we were struggling with this, but this wheel kind of gave a really powerful outlook. Is actually it's about thinking quite importantly of where we want people to help us, where we need people to help us, and we're asking people how can they help us, where do people fit, and where do people want to kind of partake, because equally some people have time and some people are very clear that, you know, they want certain support elements of it rather than being completely involved in it. So we were very mindful of this. So this, as I said, this wheel provided us with kind of different areas that we could start to localize ourselves. Well, what does this project mean and where can we fit on the wheel? Are we doing it? If so, how do we need to sustain that? And if not, where can we introduce people into the process? And that also allowed some of our team members to feel quite safe and quite capable and competent to be able to do that in a way they could manage as well. And also we also shared this with our LD, our Learning Disability Consortium colleagues as well. So actually it was a real, hopefully a cohesive approach. Next slide, please. So what did we do then? We brought in training, we were all upskilled, and then we started to look at some of our projects. And actually, we were really quite surprised that some of our projects, we are already doing it. There's lots of improvements we could do, and then there's some areas that we really do need to move forward. But in the last year, we have developed a resource pack for raising awareness of restricted practice on a national basis, and that's sitting on our website. And that was done in a very much co-production way from the moment. Because again, as I said, it's on our deliverables. But at the beginning, we brought people with learning disabilities, families, members, LD, the consortium, the third sector, and social services, and say, look, this is what we need. How can we do this? So we had people in the meetings to develop material, to develop. And what we did, we launched several workshops across Wales with all services, all providers, and all third sectors and people with disabilities delivering it in that partnership to raise the awareness through workshops. And then we developed that into a pack, and it's service user friendly, and it's really important. We've also then, from the Health Equalities Framework outcome measure, we've recently developed a service user version of this. And again, that was done through partnerships with our University of South Wales Hospital, University South Wales. And we made sure one of our key commissioning elements was that, and actually this was done through a co-production practice and approach. So we have a tool that is very embedded within co-production. We have a vision for children and young people services in Wales, which has been developed by our work stream for children and young people, and there's lots of negotiation, discussion, meetings going on with that. We also have several community practices that actually they are run by they're run by those who attend, because there's no community practice belongs to those who attend. So that's very much embedded within that, and we have practitioners and families leading that and being chairs of those groups, and our job is just to facilitate and to enable. And then we also have the Learning Disability Education Framework that, again, that was developed through that co-production approach with the University of South Wales. So these are just some of the areas that we thought was, actually we are doing well. There's some areas we could do better. There's elements of it. We're looking at trying to put the Health Equalities Framework outcome onto a digital platform. But at the moment, that's really quite difficult to involve service users and their families. We're trying to involve the workforce in that because it's their tool. Just trying to get what we mean by co-production, because we struggle sometimes because our audience are directly our workforce, but we've got to remember actually our direct workforce will impact on those with the learning disability and families. So it's trying to get that right at the right areas. So these are some of our things we think we've done well. Next slide, please. So what our key, so what we've done from that, so make sure we ensure we keep co-production within our service, within our programme. It's regularly on our agenda, and we regularly invite people. We can maintain our relationships that we have, and any pieces of work we will take to the Learning Disability Consortium. And we've also shared it with our mental health programme, our approach and our mission statement. We've also shared it with our wider organisation because they're not very good at doing co-production, and it's now on their agenda, so we're pushing that. And they've also got another ally in another programme, so we're trying to push that further. As a team, we've made a statement of intent. So our mission statement, we now developed a statement of intent. So actually we are, we're not just, it's not just inbuilt within our mission, actually we are intending, and this is how we are trying to demonstrate our use of it. And we've also, when our programme comes to an end, and hopefully we'll have a new one next year, that actually we want it to be resourced properly within our service, so we can do that in a more effective and efficient and sustainable way. So the key messages, it's really important that we enable people to make changes of their own health. They are their own change makers. It is really important for co-production to be central to all our projects, and projects, despite that, can be quite complex depending on the issue. And also the importance of recognising the opportunities, that actually there's opportunities in all elements. We've just got to be a bit more, we've got to be bold and brave and courageous, and to make sure it works. And that is me. Thank you.
Thank you, Bethany. That's a really useful and very complimentary contribution to our discussions today. It's such an important thing to do, and you've done really well. So it'll be very useful to have your contact details, and then people can get back to you and copy some of your ideas. So thank you very much for that, Bethany. I'm moving on now to Stomp and Stamp, which Carl and Dave will introduce. I think after hearing Bethany's talk, I think we should call this Co-Stomp and Co-Stamp.
Brilliant. Over to you, Carl.
Thank you, Dave, and thank you, Ashok. Hello, everybody. So my name's Carl Shaw. I'm a learning disability and autism advisor. I have lived experience of having a mild learning disability, and I work with Dave on the Stomp and Stamp project at NHS England. Next slide, please. Thanks. So for some people who might not be aware, we're just going to define what stop and stamp actually is. Well, so the stomp element is for children, young people and adults, people who have a learning disability and autistic people, their families and professionals. It stands for stopping over medication with psychotropic medications. The stamp element is specifically for children and young people, their families and professionals, and that stands for supporting treatment and appropriate medication in paediatrics. And the Stomp and Stamp programme are part of the NHS long-term plan, so that's really important. Next slide, please. One thing I wanted to talk about today was a lived experience survey. So it's very important for the Stomp and Stamp team to get the views of autistic people, people with a learning disability, families and carers. So between September last year and February this year, we collected responses to a survey we'd made. We had over 600 responses to this. In fact, I think it was 660 people responded. So we were able to gather a lot of data about the impact of Stomp and Stamp, the programme. The key things to show the survey has shown include most of the people who completed the survey had not heard of Stomp and Stamp before. We was very surprised at this because we did a lot of work in the past to raise awareness. I remember me and Dave often we used to go to conferences like this and talk about Stomp and Stamp. So we were quite surprised that most people who completed the survey had not heard of the programme before. Also, most of the people who had spoken to health staff about their mental health had been offered medication more than any other type of intervention. So that's more than talking therapies, social prescribing. Medication was up there as the highest when people were talking about their mental health to health professionals. That was the highest. Next slide, please. Thanks. Continuing about the lived experience survey, most of the people had not had a medication review. Of those who had, most people had not been told about alternatives to medication. A lot of people said they were involved in talking about their medication and making decisions about their care. However, a significant amount also said they felt they were not listened to. The side effects they reported were feeling tired, gaining weight, feelings of worry, and loss of appetite. But also, to balance things out, some positive things that people reported about their medications were feelings of calm, being more able to sleep, having fewer bad thoughts, and that they could focus better. We plan to engage with people again to think about future plans. So one thing we're planning to do is, with the information we've got from people about their experiences of taking medication, is we're going to do a series of films concentrating on those themes. So there'll be a theme about telling people what the Stomp and Stamp programme about, a theme about concentrating on alternatives to medication. So that's one thing we're planning to do in the future. Yeah. Next slide, please. Over to you, Dave. Thank you.
Thank you, Carl. Brilliant. So my name's Dave Gerard. I'm the Health Improvement Pharmacy Lead within the Learning Disability and Autism Programme. So the clue's in the title. I'm a pharmacist by background and extremely passionate that when we do consider medication for people, we balance it with what's right, what's appropriate, what will be the benefits, what are the potential drawbacks or side effects, and making sure that any decision made around medication is made with the person, with the carers, with the family, to ensure everybody's in agreement on the benefits of prescribing. I think if we think about Stomp and Stamp, it started nearly 10 years ago now, and at that point it was an absolute call to action. There was no regulatory framework, there was no mandated framework for people to deliver, but what we did come across by and large was broad agreement that it was the right thing to consider. Getting medication right, stopping the over element of medication use rather than just stopping medication. And I think in the early days, some of the messaging got a bit confused and a bit mixed. And I think people quite often heard the word stopping And it induced a degree of anxiety and concern that it was just about medication being bad and not being on medication being good. And I think that overly simplistic approach in the early days probably drove some of the early performance or lack of performance shift that we had originally intended. There was quite a focus on antipsychotics in the early days, thinking they were the major medication of use, when actually we should have been considering a more balanced message across all the different types of psychotropic medication, some of which I'll introduce you to on the next slide. So next slide, please. We do get data every year. It's not perfect, no data is, but the data set that we use provides about 56% cover of the GP surgeries in England. So in terms of the size, it's quite large, but geographically it's quite different across the country, and the information we get, we need to caveat that it's not 100%, but it does give us a clear indication on how prescribing trends are changing. Since we first started collecting in 2017, up until the most recent data set, which came out last December, we've seen some categories of medication go down slightly in terms of the extent to which they're used. One type of medication is level, but there is significant increase in a different form of medication, and that's the use of antidepressants. And much of this prescribing, particularly antipsychotics, where it says no SMI, and I'm sorry for the acronym, that means serious mental illness, is actually antipsychotics that are probably being used around the construct of behavior that is deemed to be challenging. And much as it's really reassuring to see that many of those figures are dropping over the lifetime of STOMP, and therefore it's had some impact, when you look at the final column, if you have a person with a learning disability, you are still 16 times more likely to receive an antipsychotic than someone who doesn't have a learning disability. And if you're receiving an antipsychotic and you don't have a serious mental illness, it is 20 times more likely. And that to me still raises significant questions. Why are those figures so huge in terms of having a learning disability and not? So we've therefore got much more work to do around STOMP and STAMP. Many of you will remember the pledges in the early days. I think it was signed, the first one was signed in 2016, and there's a picture of a very youthful looking Ashok Roy signing away the first STOMP pledge, and they had huge impact in terms of people wanting to show commitment to STOMP, but the delivery in terms of change, we still need to assess in greater detail. So next slide, please. What are some of the reasons why those rates potentially still seem so high? And it's the fact that many prescribers, doctors, pharmacists, nurses particularly, don't always have the confidence to change, particularly where they're working in less specialized environments. And much as the evidence base around initiating some form of medications isn't particularly strong, the guidance and the evidence base around how to take medication away safely is similarly lacking. And that's a point of contention and something that we need to consider. We've had sectors of care, by that I mean social care, healthcare, primary care, secondary care, often working in silos, not always collaboratively and in a joined up manner, and speaking to each other and sharing information has not always been in a format that's been usable in the different settings of care. So very specialist services may discharge people without clear medication plans, and a GP and or primary care network based staff aren't always confident to consider significant change to that medication. As Carl said in his survey, alternatives are not always available and therefore not always considered. And we have a postcode lottery about the availability of some of those support mechanisms. And that therefore leads to reduced confidence. Sorry, that was a bit of a double negative, but a reduced confidence. If prescribers haven't got something that can replace the medication, they're very reluctant to continue with any form of deprescribing. When we engage with people, there are families, there are people themselves who take medication, who remember what their life was like before medication was initiated, and have significant concern when somebody out the blue says, we think it'll be a good thing for you to take this medication away. So it's easier to leave well alone. Stomp and stamp will take too long if you're going to do it over 6 months or a year. There's too much risk involved, and if it ain't broke, don't fix it. So next slide, please. So one thing that's come out loud and clear from a lot of our consultation is that we probably need to define much clearer standards of practice around both STOMP and STAMP to allow everybody in every sector of care a thorough understanding of their role within STOMP and STAMP, the expectations of that role, and how this work can be considered in a more collaborative, holistic, and joined up manner. We want to pull on and look at and interrogate all the current practice guidelines and evidence base, and we want to ensure that we absolutely underpin this work through quality co-production with the emphasis on personalised relationship-based care. We need to improve confidence of the workforce to be able to deliver and feel absolutely supported to be able to deliver any form of change to STOMP and STAMP. And we want very clear messaging that it's about considering the right use of medication at the right time with really clear plans for review, monitoring and challenge should that be considered. It is not to demonize prescribing in the first place. And it would be great to consider how we get a better data set around STOMP and STAMP and to ensure we've got very clear inspection and governance frameworks. So next slide, please. Okay. Standards were an absolute drive that came out of discussion forums that we had about 12 months or so ago, some of which were heavily supported by the Challenging Behaviour Foundation. And if you look at the 5 key themes, they very much mirror what myself and Carl have been saying. Greater involvement of the person and the family, alternatives to be considered to medication, clear standards of practice, better workforce improvement and expertise, and a regulatory framework to back all this up. Next slide, please. We'll probably skip that one and go on to the next one with the times, please. Thank you. So Carl, why are medication reviews important in your view?
Yeah, thank you very much, Dave. So annual health checks are an effective way to identify previously unrecognised health needs. So annual health checks for people with a learning disability, and provide an opportunity to take an holistic view of someone's physical, mental, and emotional and social well-being. A critical element of this is a review of medication and working with the person to develop a plan about future medication needs. And that point I've just mentioned there about working with the person is really important, because how can we know what's best for a person unless we consider their needs, their views? I think another thing that's often not thought about as well is for people from seldom heard voices, so people who don't communicate with words necessarily, it's really important to also get their views. So you might want to involve the family or the carer, the supporter, make a best interest decision, and all those things are really important in terms of co-production. Okay. So also learning from the lives and deaths of autistic people and people with a learning disability. So LEADER data 2022, published November last year. So that tells us that many people are still dying 20 years earlier than others. 42% of these early deaths are thought to be preventable. Obesity is a theme from LEADER reports, and data shows it can be caused by medication. LEADER completed a deep dive into constipation. In the reviews, they looked at over 50% were prescribed medications that could have caused constipation, and that's a massive figure, of course. Medication reviews should focus on good medicine optimization, including ways of preventing ill health. And it's also important to consider the core 20+5 to focus on health inequalities. Next slide, please. Thanks.
Brilliant. Thank you, Carl. So we're very much focused on our themes of greater involvement, considering other forms of intervention rather than solely medication, really thinking about standards of practice and how we can develop those over the next few months to ensure people are clear of their role within STOMP and STAMP. But we do need that element of workforce development. So we have worked over the last few years with an organisation called MindEd that are now part of Health Education England, to produce a whole range of 10 modules aimed at different groups. So there's some of those modules that are for people with lived experience or family carers, or professionals in both health and social care who maybe have limited exposure or experience of stomp and stamp. And then we go through a range of more specialised modules to understand the way medication are used in learning disability in more detail, but also we've introduced 4 more specialised modules, which are the ones at the bottom of the list, that actually look how to safely structure a challenge to long-standing medication, to consider those alternatives that we've talked about throughout the last few minutes, and to keep people well through that process so people understand what may happen and have good plans in place to support any eventuality as any challenge to medication is considered. I'm really pleased to say that we've had those modules, certainly the first 6 for the last 2 years, and they've been completed 25,000 times, and it's growing day by day. So there's clearly an appetite to skill up workforce in a greater way, to understand their role within Stomp and Stamp, and I would advocate to have a look at those resources when you can. Next slide, please. We'll close off, and obviously these will be shared, but we have a whole range of resources we have available on our webpage around Stomp and Stamp under the NHS England web banner, but also we have Futures NHS and various other videos, resources, take away, use in your practice, use to raise awareness, because it's really important that we get this right and we build momentum over the next 2 years or so to put Stomp and Stamp back where it needs to be. So thank you for listening, and thank you for your time this afternoon. Ashok.
Thank you very much, Dave, and thank you, Carl, for your a message that is always important to hear. Such an important message.
Thank you.
Okay, thank you. So we now turn to the last presentation for today. It's my pleasure to invite Ken Courtney, who is the National Clinical Director for Learning Disability and Autism in NHS England, and he'll give us some perspectives from NHS England. Over to you, Ken.
Good afternoon, everybody, and thank you for the invitation to speak today. It's been a busy day, and I'm sorry I haven't been able to join you for most of the day, but thanks again for inviting me this afternoon, and it's good to follow Carl and Dave as well. So I'm the National Clinical Director for the Learning Disability and Autism Programme in NHS England. I've been in post since January of this year. And we've been doing quite a bit of work around, obviously, learning disability programme and also the autism programme. But today I really want to concentrate on what's been happening with the learning disability programme. So next slide. So this just gives you a lot of information about the programme itself. And it's, in essence, it's really 2 programmes. It's a learning disability programme and then also an autism programme. And although it doesn't appear to be that way, functionally, that is how it is. A lot of common areas, of course, across the 2 of them. But I do think it is always important for us to actually recognise the needs of autistic people and how they can differ from those of people with learning disability. So I just listed some of the areas there in terms of the vision for the programme and what we would like to achieve over the coming years, of course. Next slide. So many of you will know all of this information, particularly as it pertains to learning disability and autism. There's good comparison there between the 2 groups. But we do know that there's approximately 1.3 million people in England with a learning disability, 25% of whom would be registered with GPs, which is not a good figure to be honest, really, because we would obviously like 100% of people to be registered with the GP. So that brings up a particular issue for learning disability within NHS England, but also in primary care as well, in that our GPs actually detecting people who have the learning disability, they're recognising them, and because, as we know, the health outcomes for people with learning disability and autistic people are not as good as they should be in the general population, especially for people from an ethnic minority background. And we certainly know from research that people with learning disabilities will often have many physical health problems existing at the same time, up to an average of 11 per in this population, which is an extraordinary piece of data to learn about, understanding that actually people with learning disabilities have so many coexisting physical health problems. Next, please. So we often talk about health inequalities, and the Core 20 plus 5 is the innovation within NHS England to actually look at health inequalities and how they affect people in the population and the general population. And of course, that very much applies to people with learning disabilities, because there are so many health inequalities, and this is a term that you will hear repeatedly in health circles, but also outside it as well. So why are there so many health inequalities affecting people with learning disability? This is some of the reasons there. Poor access to services. Are services actually open to supporting people with learning disabilities? Do the staff actually recognise that the person has a learning disability? And the diagnostic overshadowing is a classic one, which you hear about, whereby people attribute the particular presentation, whether it's pain or other form of symptom, to the learning disability, rather than thinking beyond that and thinking, well, it could be something else that is actually affecting the person here. Tailoring clinical support to the person. So really, this is about making reasonable adjustment. And this is something that we've been working on in NHS England to ensure that services are fulfilling their obligations under the Equality Act to put in place reasonable adjustments to help a person gain access to good quality care. And what about inappropriate care? So the second point there is around medication, which Dave and Carl have actually highlighted very well. The inappropriate medication, and it's not just medication for mental disorders, but medication for physical disorders as well. And given the fact that people use so many medications, and the question is it necessary for people to use all this medication? And looking at the wider determinants of health, which is quite a hefty description of things, but really what are the factors that are causing these health inequalities? What are they down to, leading to increased risk of mortality in people? Is it to do with purely their health, or is it there other things that are going on, such as employment, such as accommodation, access to good quality accommodation, access to good support in the community? Next, please. So this is some of the areas that the programme have been working on, and this very nicely describes what is going on and how you can actually hang the activities that are happening. So the big issues for the programme over the years has obviously been moving people from hospital into the community. It's been going on for a number of years with good success, whereby we started off with over 3,500 people in hospital beds. What I mean by that is in specialist learning disability beds or in mental health hospitals. And that has come down to approximately 1,800 people in these beds in 2024. But there's still quite a bit of work to be done to support people to move into the community. And what would have to happen in order for that to occur would simply to ensure that there's good services for people to move into in the community. And this is about community transformation and therefore improving community services. So it's not just community services, but also the places where people are going to live, and ensuring that actually people will have good accommodation, good quality accommodation to move into. At the same time, of course, we have to recognise that as people are moving out of hospital, some people will be moving into hospital. The other challenge for us around that, of course, is to try and support people to remain in the community and not have to go into hospital. There will be circumstances where people will need to use hospital beds, but we want to make sure that that actually happens for a short period of time only, and for a very much managed period of time, rather than people staying in hospital for indefinitely, that is. Improving health outcomes and access to healthcare, I've described that already, but this goes back to primary care, what's happening in primary care, the innovations that are happening in primary care. Annual health checks have been around for a while, but it's not just a case of just accepting, oh, we've got annual health checks, but really it's about reviewing them and seeing how they're working and whether we're actually getting the best quality out of the annual health checks. So quite a bit of discussion and work is happening in NHS around that. But it's not just in NHS England, it has to be with primary care staff, not just the GPs, but all the members of the primary care staff as well. Children. really important because we need to get it right for children, because that's really going to have a long-term impact. Because if we can do it for children, we'll certainly have an impact on the experience that adults are going to have, because these children are going to become adults, and their use of services as well. So we really need to work on this group, and which we're already doing through the program itself. And supporting special education needs, for example, and also linking across the system, linking into social care, linking into education as well. The recent achievement around the health checks in residential schools has been a big achievement, really. Whether it'll be an improvement, we believe it will be for them, in that people will have their sensory checks for their hearing and their eyesight as well. And improving outcomes for autistic people, because what I've said about learning disability people with learning disabilities, much of that, the health inequalities, will apply to autistic people too. The one thing underlying all of this is workforce, of course, is people on the ground who will actually be able to provide the support. And it's both professional people and people who are perceived not to be so professional, but they certainly are in the roles that they're doing, such as carers, and making sure that we support everybody who is out there providing care to people with learning disability. And workforce is a really big issue, because we've got big gaps in certain professions, certain groups, but professional bodies in particular need to work on this, but with the support of NHS England. It is happening around mental health at present, but it's a wider issue. And it's not just people who are working dedicated to this group of people, but to everybody. I mean, I just keep on saying again and again that we really need to upskill the whole of the workforce, make sure that it's everybody's business. One good step towards that, of course, is the Oliver McGowan mandatory training that everybody needs to do. So that has had the beneficial effect of raising awareness, which is very positive. But what we want people to be able to do is to say, well, what next? What can I do next? And how can I get the skills that I need to support the person, whether it's in a hospital, whether it's in a GP surgery, or working in community services as well. And not just health people, but also people working in care services as well, who deliver most of the care that the person receives. Next, please. So these are just some priorities I have for what we'll be doing in the next few years. Key to it, community support and developing teams there. Reducing reliance on inpatient care. Well, that's a given, I have to say, and making sure that in fact it's people receive the care that they need, more likely in the community rather than in hospital. Encouraging research to drive improvements, and that's a big discussion. We've fortunately got work done and completed around research for autistic people, and now the next step is to help improve research, develop a strategy for research in people with learning disability. Work in partnership with families and carers, events such as this, but it's not just turning up at events, it's actually listening to people, being part of the discussions, including people. And then the last point there is around waiting times for autism assessment. Next, please. So looking to the future, and the future is not very far away. The future is here. It's starting now. The 10-year plan for the NHS, which the new government have actually announced. This is something that we all need to keep an eye on. We need to get to know about, we need to be informed about, and we need to contribute to. It's in the planning stage, but things are moving quite fast at the moment, that the government is actually keen to have the plan in place time. But in order to do that, the government will be consulting. They'll be consulting with various bodies, health bodies, social care bodies, but most importantly, they will be consulting with people and learning about people's experience, but also learning and wanting to know what people consider to be important and what people think will actually help them most. And this is where I think we working in this community, if I may say, supporting people with learning disabilities, need to be quite active, need to be active in connecting with not just your GP practice, but also your commissioners, your ICB commissioners. I'm using terms that I hope you will understand. If you don't, can you educate yourself around integrated care boards and NHS regions, primary provider collaboratives, for example. So really connecting with your local services, whether it's in a hospital or in a community service, and being able to tell them what you will actually need to gain the best outcomes for yourself and reduce those health inequalities. So all of that was backed up by the Darcy review. I'm not going to go into it, but you may have heard about it, but basically saying, things are not really good, we've got to repair it, therefore we need a plan. So this is some of the areas there. But these are the factors that will actually help on the right-hand side there. Workforce is key to it, making sure that people have the right skills for whatever the job that they're employed to do. Whether they're employed as a dentist, for example, that they understand how to provide dental care to people with learning disabilities. And working across the systems, that's bodies, but also organisations such as CBF, such as BenCap as well, must be working together and contributing to developing such a plan as this. Making best use of money, really. So it's all valuing for money. People will say that there isn't any money left, but well, whatever money you've got now, how are you going to make sure that you get the most out of that pot of money that is available to you? And of course, going back to what I was saying earlier, making sure that any decisions that are made in terms of developing systems, developing models of care in health are actually backed up by the evidence. There's no point in producing a model that we think is going to work, that we think is effective, that we think is something which will really help people, and one that we like, if it turns out that it isn't going to work and it hasn't worked, or unless we actually conduct the research. And if there is a new model which is proposed, well, then it must be joined up with an evaluation system built into it, a way of gathering the evidence, of gathering knowledge around outcomes and how it is actually working for people. Next. So that's all from me, and I'd welcome any comments, or you can email me directly at NHS England if you do. I think my email address is on the first slide or not, but Viki, you have, so you always know where to get me.
Well, thank you very much, Ken, and you'll be glad to know that over 100 people are still here listening to you, which is really quite something.
And they'll all be emailing me. Is that what you're going to say?
Yes, they'll be emailing you now as we speak. Anyway, so that brings us to the close of our conference. I just wanted to thank all our speakers who made such excellent presentations along the topics of interest that we had today. Thank all of you staying back and listening to the whole thing. Just want to remind you that the Senate slides will be the link. The slides from today will be sent to you, and the proceedings of this whole conference has been recorded, will be eventually available once it's ready. Just wanted to say that from today, some key themes that seem to come across to me were sort of professional excellence and workforce issues and shortages. After all, we are a low-tech specialty. We are the people who are the therapeutic agent, and we must be confident and positive to do the work. There's a lot of talk about team working, but more importantly, working as networks that surround people with learning disabilities and their families, having shared values and beliefs, which chime with the hopes and aspirations of the people that we serve. And above all, achieving this through non-stop partnership, working with people and their families, so that we are doing the right thing and not just doing things right, so that we get better outcomes in a very, very disadvantaged section of our population who have really very poor health outcomes at the moment. So there's a lot to do. So that's really all I had to say. I want to thank all the people from the Challenging Behavior Foundation, Gemma and Florence especially, who worked day and night to make this a success and a pleasure for us to chair. So thanks to them. And that's really all and I'll just leave a few seconds for Viki to add a few comments in case I missed some.
I don't think you've missed anything. Just a thank you from myself as well. And thank you on behalf of everybody at the Professional Senate that have helped to put on this conference. And yeah, take the energy, the inspiration and the ideas and work together to stay well. Thank you, everybody, and have a good rest of your day.